with Doctors Jeff McGowan on stage, as well as Dr. Abby Brackney. This is a huge effort, and it's a three-part team. I'd like to start with thanking Maddie, Christy, and Belinda. Without you, this event would not have been possible. No way. Pulling all of this together virtually during a pandemic has truly been a Herculean task. And I want to thank all of you for joining us today for our first of 3 virtual MCEP Summer CME events. This is number 1. And although we were disappointed to have to cancel our summer assembly, we are absolutely thrilled to have you here and be able to provide virtual CME to you this summer. We are really excited about the lineup of speakers and topics today. We have a nice variety. We have several surprise guests, and they've sent messages to share with you today, and those will show up throughout the morning. So we are able to offer the CME today to all of you free of cost, and that is thanks to ProAssurance, who is our sponsor today. They recognize the importance of continuing education and the financial impact that COVID is having on you, with some of you having shift reductions and some also elimination of your CME funds or reduction. So to claim CME, that's the important part. To get your CME today, please make sure we can see your name as you've logged in today. And we're going to monitor whose name it is, and then we'll send an email after the course with instructions to claim your CME. For our DOs in the audience, to get your Category 1 AOA credit, we are going to need your AOA number. So again, this will all be in the email following the event. If you forgot to register, then make sure you register, and we'll remind you throughout the day about that. Also, if you're logging in from a cell phone and only your cell phone is showing, just email us your phone number and we'll link up everything so that you get your CME as well. If you have questions for our speakers throughout the day, please use the chat function. We'll be monitoring that as co-directors, and we're going to ask the speakers your questions at the end of their lecture so we can keep things moving. But if you want to personally ask your question, just make a note of that in the chat next to your question, and we will make sure we get that opportunity for you. Also, feel free to post liberally throughout the entire morning in the chat box. We'd love this to be as interactive as possible while keeping the event rolling. So please chat away, and we'll be out there chatting with you too. Also, to make this even more interactive, which again, this is just so different obviously than being in the Grand, but we got this for you. We're going to have a few poll questions, and those are going to pop up probably in the middle of your screen periodically during lectures. And those are primarily just to get some conversation rolling. We're not using them for any other purpose. You're welcome to just close the box or join the conversation. And then we're going to share those results with you as well throughout the morning. But if you see a question pop up, that's from us. And it's not a secret research study. We're just, we're trying to engage you a little bit. So without further delay, and also of course, as always with Zoom, if you're not talking, we'll ask you to stay on mute, and we'll absolutely be able to unmute you periodically. So without any further delay, it is my greatest pleasure today to introduce to you all Dr. Nicholas Dyke, our brand newly inducted MCEP president as of yesterday, to formally welcome you all this morning. Welcome, President Dyke.
Good morning, everybody, and thank you, Therese. It is my distinct honor to be here with you guys as we welcome you to the first of 3 MCEP Summer Series webinars. I'm currently in the vehicle with our friend and colleague, Dr. Rami Khoury. We're going to be viewing today remotely from beautiful Jonesville, Michigan, as we spend the next couple of days tenting with our families. Thanks to those who have made these high-yield 2020 relevant lectures, and thanks to everyone for attending. MCEP is the regional leader in emergency medicine. MCEP prepares the most relevant, up-to-date lectures that impact our patients. You're about to hear phenomenal lectures on resilience by Dr. Hope, airway management in the setting of COVID by Dr. Walters, a foremost expert in emergency airways. Dr. Walters was a first-generation ED resident at Columbia University. He can tell stories about having to explain to surgical subspecialists over the phone that he's a resident in emergency medicine, a foreign concept at the time. You'll hear about COVID in kids by a regional pediatric expert, Dr. Pam Coffey, and non-clinical physician side gigs, a topic of interest to myself and many others, by MCEP's president-elect, Dr. Greg Gaffney-Pappas. This series is set to be the most instructive 3.5 hours of education this summer, so much so that we have the honor of some shout-outs from our great state leaders. And I'll segue that back to you, Therese.
Thank you.
Unmute.
Therese, you're muted.
No audio. Okay.
Just give us one moment to get the audio rolling. Maddie, we are still no audio.
Guess I don't know what the issue is because we just tested it right before. I can hear it.
No worries, we'll give it a second.
Okay.
I want to thank all of our emergency physicians on the front lines for protecting Michigan families and saving lives over the past 4 months. You have showed unwavering strength, humanity, and grit throughout this crisis, all while putting your own health, your own lives on the line to protect the rest of us. We would not be able to get through it without you. Thank you.
All right, with that wonderful shout out from our governor, we're going to get started with our lectures next. Our first lecturer is an attending at Beaumont Royal Oak, Michigan in the emergency department. She's an assistant professor at OUWB School of Medicine, where she teaches the students behavioral change and motivated learning. She's also author of book Habit That. She's an avid reader, frequent podcast guest where she speaks on healthy habits and confidence in overcoming the imposter syndrome. She also tries to love to hide vegetables in all foods, including desserts, but yet she remains non-judgmental about my Diet Coke habit, as she's one of my good friends. She's an all-around good human being. Jamie Hope is here to discuss resilience.
Hey, black bean brownies are more delicious than they sound. She's shaking her head. She's like, no, they're not. All right. Well, good morning, everybody. Thank you for being here with us. For those of you who have your camera on, do you have your coffee, your tea? Let's see what our beverages are this morning. Cheers. Cheers to everyone. For those of you who don't have your camera on, feel free to turn it on if that makes sense to you. And I know because nobody at this point is judging the background or anyone's appearance, because we all get to do this from home. For those of you who are not maybe as familiar with Zoom, if you look at the bottom of your screen where it says reactions, there's a thumbs up and a clap, and so sometimes that's a fun way to participate. So everyone who can figure out how to do that, give me a thumbs up on your reaction. All right. Good. Excellent. And then it does just go. And if you're curious on how to change your name, if you wave your mouse over your picture specifically and see the ... and click on that, it gives you an opportunity to rename. So I know that they said they want your real name. I've seen some rather creative names in Zoom meetings, something like Princess Consuela Banana Hammock and stuff like that. It makes it hard to call on participants. All right, well, good morning. I'm honored to be here today. We are talking about resilience. And oh boy, has the pandemic given us an opportunity to really examine that. One of the important components of resilience is adaptation, the ability to be adaptable. And think about it, in emergency medicine, from back in the time when Bradford Walters was roaming with the dinosaurs, and that started, the field changed over time. And I was thinking about, and chatting with my husband last night, who's also an emergency medicine physician, the ways that medicine has changed. When I was first an ACLS course instructor, when I was a resident in 2005, do you guys remember what we used to do? We used to shock, shock, shock. No break between the shocks. We weren't concerned about the circulation. It was all about airway. and all the meds, those super complicated algorithms. And then AMEO came along, and then all of a sudden it was AMEO for VTAC, AFib, AFib, ankle sprains, AMEO for everything. And so we saw the changes over time, and we've learned to adapt. Even in my practice lifetime, if when I first started, if someone said the magic words chest pain, odds are they were staying at Hotel Beaumont that night. And now we have continued to adapt our practices based on best practices, data, and all of those things. COVID was and is such an incredible time of adaptation. And I want to give a shout out because I feel like we handled that really well. How many of you, give me a thumbs up if you would come in, you work the shift one day, you come in the next day, and the policies or procedures for COVID are totally different? How many of you guys saw that happen? Yeah, a lot of thumbs up. Or you can, or the people who have the camera on, you can just give a thumbs up or wave or anything like that. How many of you actually saw it change during a shift? So we saw those major changes. And so we tend to be very adaptable people, and I think it's what draws us to our specialty. So this is to honor the fact that we are very adaptable and have some strategies to augment that. Because just because we are being adaptable doesn't mean that things aren't also difficult when all this is going on. There are a lot of talks about burnout and physician suicide. There are 400 physician suicides on average per year in the United States. That's more than one per day. But when people talk about burnout, I think that term gets thrown around the wrong way. Because what it is, in a lot of ways, is victim blaming. So we practice medicine under a microscope. So we've got the litigation stress, we have constant changes in policies and regulations, all these meds to know. I don't know about you guys, but I mean, I've certainly had patients yell at me, spit on me, try and hit me, all those things. So we practice in an environment that is stressful at baseline, and then add a pandemic on top of that. So now we're dealing with our own fears about our health, our jobs, and our family members. I have an elderly grandmother who is overweight, COPD, oxygen dependent, diabetic. It's pretty scary to think about her getting COVID. So we're treating the patients, and we still all have the rest of that weight of the COVID. So this is to just augment some of those awesome strategies that we already have. We are adaptable people, and there's lots of different other things we can do. Now this morning, you may have been emailed a worksheet because we're ER people, and sometimes we do things last minute. We like to make little changes. If you didn't get it, if you don't have it, it's okay. I'm gonna show it to you here. I have this really fun overhead camera. If you're seeing everybody in the Brady Bunch view, it might be a little difficult to see this. If you go to wave your mouse over the top corner, you can choose speaker view just for this part so you can see the worksheet. So let me go to that. There we go. Okay. Abby, somehow speaker view is on you. I don't know why. I like seeing your face though. No big deal. I'll go back to gallery view. So on here, you can see it's a much smaller view now, of course, but that's okay. So this is a worksheet about resilience. And this isn't something that you have to do during the talk. It's to spark your thinking about the stuff that we're going to go over. And it talks over here about looking at the bigger picture. So the first space is a peak experience moment when your resilience was high. So getting you into the mind frame. So when was a time that you were feeling particularly resilient and things were going well? What type of strategies were you using? What was your self-care like at that time? What were your meaningful connections with other people, and what was your support system? So when your resilience was high at that time, look back at all of those things that helped it be high for you. And then the question, why is it important to work on resilience? Now, this isn't saying that any of us have a personal failing, but the more resilient we are, the more able we are to make positive changes in our own lives, in our families' lives, and in the system. So this, how can we question about resilience and culture and system level changes? And what I like about MCEP is that it focuses on us as individuals, helping us with patient care, but also the bigger pictures and policies in societies. So on the second page of this, there's blank spots. So you can write down strategies as they occur to you during this talk and over the next coming weeks. So it's divided into 4 boxes. So personal strategies, ways that you can help with your colleagues and coworkers to help them with their resilience strategies, things that we can do for culture and society when the world is stressed, and then systemic changes, such as looking at things like institutional racism, tort reform, and all of those type of things. So by having that strong resilience in us as individuals, it gives us more energy to make those positive changes on a more macro level. So, so we're going to talk today. We're just, I'm being mindful of the time here. So 5 concepts and mindsets that we're going to go through, and then 5 strategies that you can actually do in your real life at home, something actionable. I like people to walk away with something to do. So the first concept that I want to talk to is about the concept of renters versus owners. And you know that what you're talking about. So renting or owning a house. When people are renting a house, they might not be as careful. They might scuff the walls, make some holes to hang up pictures, rough up the carpet a little bit. Ultimately, it's not their long-term responsibility. So they're not investing in it. Whereas the owner is investing in the house, making repairs and necessary upgrades. And so that concept also applies to us for our personal health, for our relationships, and our careers. Now, sometimes when we're stressed, we treat our personal health a little bit more like a renter than an owner. And that is, you know, when we stay up late, maybe have a couple glasses of wine, eat a bunch of chili cheese Fritos, and binge on Netflix. So occasionally I know that we do treat ourselves like renters rather than owners, but I want to help everybody internalize that concept. Owners invest in themselves. So in your health, what that looks like is getting nourishing food, energizing exercise, restorative sleep, stress release, and meaningful connection. That's my favorite mantra. You'll hear me repeat that at least more than once. Now, as owners of our relationships with our loved ones, families, and friends, that looks like making the time for them, caring about them, listening to them, those type of things, investing in it. And for our career, investing in ongoing improvement by doing things like this, where you're learning new strategies, where you're coming to talks, where you're connecting to people, hearing from experts, and also sharing ideas amongst each other. You can practice, after the first year you practice as an attending, you could continue to practice medicine like that for the rest of your career, but you've really not improved. If each year you get better, you get feedback, you check on your patients after they've been admitted or discharged to see if you were correct, all of those things, and you invest in yourself. So I invite you to embrace that renters versus owners mindset when it comes to those areas of your life. So thank you for taking ownership of your career specifically by showing up for this today and staying connected. I think that's wonderful. The next concept is react versus respond. And we're all doctors, we know what this means. So if I give you a new medication and you react to it, it's probably going to cause some swelling, a little breathing issue, probably some kind of icky rash. Not you being at your best. If I give you a new medication and you respond to it, it means that you are getting better and improving. Now, how many times in our lives have we reacted to a situation rather than responded? I remember a very specific patient who was one of those, and this will likely be familiar to all of you. You've probably seen her too. I walked into the room, had barely introduced myself. She has never met me before, and immediately she's already like, "You're the most wonderful doctor I've ever met, and you're so nice and pretty and sweet and kind." And then when it turned out that I wasn't going to give her Dilaudid, it flipped, and she called me a curse word I won't repeat on here, but it was really creative. Instead of just the B word, it was a donkey-faced B word. So I at least appreciated the creativity, and then told me I was, and I quote, literally the worst doctor in the history of the world. That was over the course of just a few minutes, so I really don't think that I got that much worse in those few minutes. But fortunately that day, I was well rested. You know, I'd had a good night's sleep. I ate something before I ended up with that patient encounter. I even had gone to the bathroom first, so I didn't have a full bladder. I was in full just respond mode. And of course, my response was, you know, "Sorry you feel that way. How can I help control your pain in a way that's safe for you? Just normal. But sometimes if we are tired, exhausted, frustrated, just saw something terrible, and a patient comes at us like that, we're human and it's normal to want to react. So keeping us is with those resilient strategies, keeping us out of the react mode as much as possible, because then you're a lot less likely to get a letter from somebody. So the renters versus owners and react versus respond. So I'm going to tell you a little story about how I definitely did lots of those things wrong. I walked into a shift and I was feeling pretty nauseated and my stomach didn't feel very good. And so I asked the smartest ultrasound doctor that I know, smartest, most talented and wonderfulest, Dr. Abby Brackney, if she would take a look at this gnawing pain in my right lower quadrant area. She wasn't able to identify the appendix, but she said the whole area around it looked awfully angry. And so what did I do? Did I get expert medical attention? Of course not. Continued to work my shift, went home, did all the usual stuff, came in for my shift the next day where she saw me and just gave me the look. It was a priceless look. Continued to work my shift that day, starting to feel sicker and sicker. Then did I go get help? Of course not. I went to my grandma's 86th birthday party. Then I went home, put my kids to bed, took a shower, and drove myself to the emergency department. So lots of different things going on here that were not ideal. But when I woke up, so I didn't tell anyone. So I had my emergency appy in the middle of the night. Only my husband knew because, I was leaving. And the next morning when I let people know, my friends and family immediately offered help. We can go grocery shopping for you. We'll bring you food, play with your kids. What do you need? And it might have been the anesthesia talking, but I said yes to everybody who offered to help me. Now, thumbs up. How many of you are terrible at asking for help? Let's be real out there. Yeah, thumbs up, hands up. I see some thumbs that are not up. I'm guessing you're either lying or going to get coffee. So yeah, I'm not great at asking for help. And for those I didn't even ask, they offered help, so I accepted it. So I tried this all-in strategy where everybody who offered to help me, I said yes. And you know what? I did not burst into flames. Craziest thing ever. So asking for help and accepting help when it's offered to you, even if you didn't ask, can make a big difference. We tend to be a little macho in emergency medicine where, oh, it's fine, I could see 500 patients and intubate 2 people at once, I don't need help. But that's not always the most beneficial strategy for your patients and for our own lives. So the concept here of asking for help and accepting help, even if you didn't ask, makes such a big difference. Also, not ignoring the problem because, the appendicitis isn't going to go away. Mine was only leaking by the time they took it out, Abby. It didn't fully rupture. So it's cool. It's fun. All right. So in the body, we know where the appendix is, unless the patient has situs inversus or some type of weird anatomical variant. Generally, the appendix is located in or about the right lower quadrant, right? But how well do we otherwise know our bodies and where our stress manifests? So I ask you, this is you. I had a little more human looking model, but my kids hit it and I don't know where it's at. So we're going with this. Adapting. Where in your body do you manifest stress? Because sometimes we like to pretend that we're not stressed. Like, well, I'm fine, but you have a crushing headache or just that tension headache, the clenched jaw, the tightness in your neck, when your shoulders are up to here and you're like, I'm not stressed. Get it in palpitations or in chest pain, or you get it in your belly where you get a little nauseated or queasy or some constipation or diarrhea, tightness in your legs or jitteriness in your body. Or how about your mood when you're stressed, especially when you're telling yourself that you're not stressed and you're totally fine? Do you tend to get a little bearish, like snappy, angry, grumpy, quicker temper, or do you tend to withdraw and not talk and say everything is fine? So just like appendicitis, when we can diagnose the way that stress is manifesting in our bodies, even when we're pretending it's not there, that is a really helpful key. So I invite you to think about yourself and where in your body your stress manifests, because that's going to help with the next step. So that is your stress scale. Just like the pain scale, having a concept of how stressed you are definitely makes a difference. And that varies based on people and situations. So in my behavior change course that I teach for the medical students, one of the things we have people do is write out a stress log. So imagine people, places, and situations in your life that you commonly encounter. And how do you feel around those certain people in those situations? Holidays, parties, of course, that's changed now because of the pandemic, but just in general. And when you are thinking about it, put yourself in the mode. Imagine you're with that person and see, okay, how do I feel? Is my jaw starting to clench? And that gives you that awareness, so you know, okay, ooh, these certain people, situations, places, things tend to stress me out a little more. I feel it in my jaw. This is what, and you know, it's a level 7. Then you have an easier concept of what you can do about that kind of stress. So knowing where you are in your body and how you behave when you're stressed gives you that opportunity. So, and the last of the concepts we're going to talk about here is stress hard versus stress soft, and then we're going to go into 5 resilience type strategies that you can use at home. So the concept of stress hard versus stress soft. When you're at a high level stress and you have that headache, or your stomach's upset, or your shoulders are up, anything like that, there are lots of different ways that you can release stress. And a lot of people focus on what I call the soft stress activities. So that's, you know, petting a fuzzy pet, hugging something, listening to soft music, deep breathing, relaxing, stuff like that. And those are great. Those modalities are extremely helpful. But what about the days that you're not feeling that soft? You see somebody like a horrible victimization at work, something terrible that somebody else did to somebody else. And you have that feeling of the second victim syndrome, having witnessed that type of thing, and you're mad. Something, you know, when something bad happens, it's mad. I'm not feeling soft in that moment. I'm feeling primal. I'm feeling frustrated. It's awful and it sucks. I still remember the 22-year-old patient I coded during the COVID outbreak near the beginning, and the sounds of her parents screaming. Those type of things activate that visceral sympathetic response. And so sometimes you're not in the mood for a fuzzy bunny. So my concept here of stress hard versus stress soft is a way to honor those feelings that we have, because not all the soft strategies work when you're feeling hard. But there are safe ways that you can release that hard stress, because it's important to let it out. Otherwise, it eats us alive. So for some people, that means lacing up some shoes and pounding the pavement on a run or a hike, or pounding a punching bag. There's a racket and pillow technique that you can do where you take any type of sports racket and whack your pillow. And there's even something called dish therapy. That does not involve washing the dishes. It involves something like a very cheap garage sale set of dishes and a smashing party. Now, it's actually very satisfying. I've done it before. There's something about the breaking something. But here's the thing about that. If you're gonna do something like that, smashing it into a metal garbage can gives the 2 benefits of being really loud and viscerally releasing, and then you don't have to clean it up. My rules are, if you are going to do any type of smashing to help release your primal stress, that's okay. Do not break anything that does not belong to you. Do not break anything irreplaceable or that you chose in haste. And please wear protection, because I assure you it will not relieve your stress if you come into the emergency department with some glass and cheap dishes in your eyeballs. So I know I see someone for the smashing party. I know it sounds crazy for people who haven't heard it before, but it's super satisfying. So now that we've talked about awareness of where the stress lives in your body, so you know it's there, and your stress scale, and what people and situations and places cause the most type of stress, and this permission to honor what you're going through and stress hard versus stress soft. And you can use any combination of those type of strategies. Honor what works best for you. So we're going to get into the 5-step process here that I like to call empty. So empty your stress. So the E stands for eliminate. What things can you eliminate? And that can also mean automate, delegate, or donate. You don't have to just throw everything out. So for donate, since we apparently had a little extra time on our hands, we started going through my kids' play areas and purging out a bunch of toys and stuff that they don't play with anymore, and then donate those. For automate, sometimes it takes a little bit longer to get everything set up if you want to do online banking or budgeting, get all your tax stuff all in one place, but a lot of time that you make to set it up will save you time downstream. Or even delegating tasks that aren't the best suited for your time to somebody else. I had several lectures to prepare and a chapter that I was writing, and a lot of dog poop in the yard. I have 2 big rescue dogs. So by delegating the dog poop cleanup, which most people could do, I needed to be doing the thing that I needed to be doing, which was writing my talk. And so that just helped relieve that off my thing. And then I realized, wow, there's a whole lot of stuff that I shouldn't be doing. So now I make my kids put away the dishes and laundry and everything, and it's great. So what this pandemic has taught us are that we can actually eliminate quite a bit of stuff. How many meetings that we had could have been an email? All of those different things. So what in your life, particularly when you look at that list of stressful people and places and stuff like that, what can you eliminate, automate, delegate, donate? Things to just get it off your plate. Okay, so the M is for minimize. Some things we cannot get rid of. Some people we can't fully cut out of our lives, unless you guess a good way to get rid of them now is just and then people scatter. But how can you minimize? I know I sneezed in public. I'm like, oh crap, allergy season. Well, that sure got me a place at the beginning of the line though. Minimize. And so minimizing your exposure to that person, place, or situation, and also maximizing your self-care going into and out of it. Because you don't want to react, you want to respond to those situations. You want to go in well-rested and all of the other types of self-care. So truly looking at that list that you're going to create, what can you minimize out of your life? So for P is people. And for this is a concept of 5 people. It's based on the Tracy Sanson principle. So 5 types of people to have in your life. Number 1 are the luminaries. These are the ones you are learning from. You read their books, you listen to their podcasts, their lectures. They could be colleagues, they could be people, they could be famous people, they could be your kids. I mean, we learn from tons of people. But who are you learning from? Those type of role models that help you continue to improve rather than stay the same year after year after year. There's a good expression that you would be the same person you are 5 years from now, except for the books you read and the people you meet. And so that concept is really good. So who are the luminaries in your life that you want to learn from? And make sure you make time for that in your schedule. Number 2 is, who is your fail friend? Fail friend. When things go wrong or we make a mistake, and inevitably we do, not everybody is comfortable sharing that publicly or just broadly with everybody else. But holding it inside doesn't help. Now, I won't ask for a thumbs up or a hands up, but just know to yourself, how many people have been named in a lawsuit? Or know somebody who has? Or found out later that one of your coworkers did and never said a word? And a lawsuit, of course, is not a failure, but that sure is a stressful thing. Or if you just did something wrong, you overreacted and yelled at your kids or your spouse or something like that. Someone to talk to you that sees you, and they're not going to judge you and tell you you're a terrible person. They're also not going to say, oh, that's great. No, continue to yell at your kids and mess up. It's not that kind of thing, but someone that can hold that space for you to be able to talk about it. So number 3 is your tribe. And it's good to have more than one tribe. So you've got your golf buddies tribe, your girls' night tribe, your travel tribe, your family tribe. These are the people that you get to be around and just be yourself and have fun. You have those things in common. We're an EM doctor tribe here. We all have an idea of what each other's working lives are like. And so staying connected even on platforms like this are important. So having your tribes and then finding ways to spend time with them even during the pandemic. add a couple, you have Zoom happy hours with your friends and things like that. Just really important to stay connected with that tribe. Humans are not meant to be solitary beings. Number 4 is, who would take a bullet for you? Not who would you take a bullet for? I want to be crystal clear here. Who would take a bullet for you? That is an indicator of how you are showing up in your relationships for other people. If there is no one on that list, consider perhaps getting closer to some of your relationships and spending more time with people. It's an indicator of how you are showing up in relationships for other people. And then number 5, who are you lighting the way for? Because you are also a luminary and a leader. Who are you helping? Who is learning from you? Who are you guiding, mentoring, and making a difference for in their lives? Can you imagine if you have multiple people and a robust list under each of these 5 categories, how enriching life would be? So that's the 5 people. And that is the P in empty. So for the T is thankfulness. They have done so many studies about the importance of gratitude and how it significantly releases and reduces stress in so many ways. Now, thumbs up, who has a regular gratitude practice of some kind? Thumbs up, hands up. Okay, good. I'm seeing some people pop up. Okay. This can be as simple as, at the end of a day, writing down 5 things you're grateful for about that day. And I do this with my kids too. We do this a lot. As the saying goes, there's an app for that. So you can find a gratitude journal app, and you can even find one that'll ping you reminders in case you forget. When you are fighting with your significant other or mad at your kids, a really important practice is to take a deep breath and say out loud or to yourself 5 things about them that you're grateful for before the argument continues. It doesn't mean that they didn't do the stupid thing that you're mad at them for, but it just helps recenter you into the bigger picture of who they are. So who thinks like that's a reasonable thing to try? Who's willing to try that? Give me a thumbs up. Who's willing to try a gratitude practice? Give it a week, see how it goes. Something? All right. It makes a difference. So just very simple type of things, but they have proven over and over that makes such a big difference. And the Y in empty is you time. So self-care isn't selfish. In fact, you can't fix the world with broken hands. You can't carry the weight of the world with a broken back. And as a lot of us very honestly and authentically said, we kind of suck at asking for help. You time is an important thing that it's to schedule and make sure you take care of yourself. And again, this is back to my mantra of self-care, which is nourishing food, energizing exercise, restorative sleep, stress release, and meaningful connections. And I gave all those words a descriptor on purpose to make sure we're not just talking about sleep. Well, you could get 2 hours of sleep, but that's not restorative. So I ask you guys to picture it like a table. So imagine you have a tabletop and everything you love is piled on top of that table. Your family, your loved ones, your career, your dreams, ambitions, hobbies, everything in your life is piled on that table. And the legs of those tables are supported by those pillars of health. The food, the exercise, the sleep, and the stress relief. If you ignore one of those table legs, your table will start to get wobbly. If you ignore 2 or more, eventually that could all come crashing down. And instead of coming in for a shift to see patients, you could end up coming in as a patient. So medical people tend to not be the best at this, but I would love to remind you, self-care isn't selfish. And so I schedule it into my day as if it were an appointment like any other type of thing. And what I do in my habit courses where I teach the medical students behavior change, there's a longer course where I teach them barrier busting because motivation is very fickle, and smarter goal setting. So if that's something that anyone's ever interested, feel free to reach out to me. It's one of my favorite things to talk about. So goal setting and barrier busting, and it helps people turn their goals into habits. All right. And so the last thing, just to kind of wrap up here, and then I'll give you the slides with the last stuff on it, is the concept of stress growth. So if you look at resilience, people often describe it as, you know, a ball that gets deflated or, you know, kind of banged up and then goes back to its original shape. But stress growth is the concept that you not only get back to your original shape, you get better because of that stress. Look at the case of Malala Yousafzai. She was 15 years old and was dragged off a bus by Taliban and shot in the head and left for dead because she had the audacity to want to educate girls and women in her country. Now, she survived, as you well know, and instead of being a regional leader and advocate for literacy, education, and safety for women and girls, she became an international symbol of hope and became better. I'm not saying that I'm glad she was shot by any means, but she was shot and came through better on the other side. So Immaculée Emmanuel was trapped in a room, a tiny room, for 91 days with 6 other women to escape the Rwandan genocide, and came out and became an international beacon for hope for refugees and against genocide and slavery. So Esther Chu, I don't know how many of you guys know Esther Chu. She's an emergency medicine physician. She's very famous on Twitter. She got frustrated at the discrimination and lack of gender equity. So she created a platform so she can come to a company or hospital and help them evaluate and learn to do a better job on that. I mean, there's so many people and things that have done this. So the pandemic is stressful. Emergency medicine can be stressful. How might we come through on the other side, connected to a purpose that makes sense for us, and become even better people? Human trafficking is one of the areas that I work in advocacy. And so that has changed during the pandemic, the way that people are trafficked, but it's still happening. So I'm continuing to grow, make contacts with people, and do everything I can to educate doctors and medical staff how to recognize human trafficking. So whatever cause is important to you, medicine or any of those things, it doesn't matter what the cause is, it matters that it matters to you. And there's 3 ways that you can support any cause, and that's time, talent, and treasure. So donating your time, donating your talent, so your abilities, your connections, your medical expertise, anything like that, and treasure. Of course, all of these need money. So, all right, so this is the very quick recap here I'm going to share now. Host has disabled screen sharing. Can we have screen sharing now? It'll be super quick.
Yes, sorry. I will do that for you right now.
This is our new reality. No worries. I can't believe my kids and dogs haven't busted in here yet and tried to be part of this.
Okay, you should be able to now.
There we go. And share. So this is just the super quick recap of all of the journey that we took today and the 5 concepts and any of those. So renters versus owners, react versus respond. So stress and the need for resilience is not a personal failure. It just means being a human. Remember the terrible example of my bad choices around my appendicitis, and know that it's okay to ask for help and accept help, and don't ignore the problem. Oh, good. Now my dogs are barking in the background. I didn't think I was going to make it through a whole Zoom call without that. How does your stress manifest in your body specifically? So it helps get you towards better recognition and knowing your stress scale in various situations. Giving yourself permission to recognize what you're going through and stress hard or stress soft. Empty your stress, as we talked about, and the concept of stress growth. How might we come through a terrible situation as a better person? All right. So, I mean, you can take pictures of that or anything that you need, and I'm happy to share that with anybody. So, with that, I thank you for your time. I know it can be more difficult to sit virtually and listen to something. Thank you for the people who have their cameras on, because it just feels so human to connect. But even for those who don't have your cameras on, thank you so much for being here and continuing to take ownership in your own personal and professional growth. Thank you. Zoom applause. Thank you. Nice. I love it. Thank you.
All right. Does anybody have any questions for Dr. Hope? Didn't see any questions in the chat, but if you want to type your question or just unmute yourself and go ahead and ask. All right. Thank you so much, Dr. Hope. That was a great talk to start off our morning. We've got a poll coming up.
It was great, everybody. We got 59 participants currently. All right, well, we see the poll results here. Looks like administration issues is number one, which I guess probably none of us are too surprised by. But thanks for answering those polls. And thank you, Dr. Hope, for giving us that great talk.
All right, so we're going to keep going. We're going to just wanted to remind everybody about the CME email that you're going to get. Oh, got another poll here, huh?
Yeah, I'll jump in as well. Yeah, we were going to remind you about the CME email that will be sent out from MCEP. And then Amazon Smile, I actually did it myself yesterday because I had not had a lot of experience with Amazon Smile personally. Takes like less than 2 minutes. You can connect it to your Amazon thing, and we actually can set it up for doing the Michigan Emergency Medicine Foundation. Like I said, it took me less than 2 minutes to do, connected to my regular Amazon account. Again, it donates essentially like 0.5% of eligible purchases. And again, it's no cost to the user. So it's actually like a kind of a cool, easy thing to do that can kind of help kind of our Michigan chapter foundation there as well. Next, we're going to do is we're going to do our next shout out. We have actually one of our U.S. senators, Debbie Stabenow, actually gave us a shout out, which was awesome that she was able to send us over something. Maddie, you can go ahead.
We'll set that again.
All right, our audio disappeared on us again.
Maddie, you have to unmute.
That makes a lot more sense. Okay.
To all of my friends with the Michigan College of Emergency Physicians, thank you so much for everything that you have been doing always, but particularly during these last number of months and as we continue on this pandemic. I don't need to tell you how tough it is. You're on the front lines. But I will tell you, as somebody whose entire family's in Michigan, I'm extremely grateful for your incredible hard work, your dedication, your competency, your courage. To me, that defines a hero. So thank you.
All right, so we are going to get started with our next speaker. Our next speaker is the Assistant Residency Director at Beaumont Royal Oak. He's a longtime MCEP member. He is winner of the 2019 ACEP Council Curmudgeon Award, which makes perfect sense to me. He's a master of all things airway with the ability to intubate anyone or anything that can't run away fast enough. With his knees, though, lately, maybe that's less and less. Here to talk about airway management in the time of COVID is Dr. Brad Walters.
Mandy, how to screen sharing, share my screen.
Green button at the bottom, Brad.
In the middle.
Yep, got it. Share. Did that come across?
It's looking good.
Looking good. All right. So what I want to talk about today is the airway management in the COVID era. I think we have a unique little opportunity because at least at Beaumont Royal Oak, we've had a bit of a hiatus. We're still seeing COVID patients, but not quite to the extent that we did in March. And I think that that's true across the state. Nevertheless, as of yesterday, again, the United States set a record in not only just a number of cases, but deaths. I think a lot of that is because our testing is better, but it's still not up to snuff. So I think we can kind of take this little bit of time to kind of review some of the things that we have learned about managing the airway in the COVID era, which is difficult. I have no disclosures, and of course, my goal in life is to be the person my dog Winston believes. So why is this important? Well, patients who are infected with the COVID virus seem to have a unique response. It's a marked challenge, not only when they're intubated, but managing the vent, the pathophysiology, the pneumonia, the respiratory decompensation seems to be really unique and something that we are not necessarily seeing with other viral entities like bacterial or other viruses. And it changes. It changes virtually every day. I know that I was adding information to this talk as of last night. And so one of the other interesting things, and correct me if I'm wrong, I am now seeing patients who then tell me that they were sick with COVID earlier in the year. They're now returning to the emergency department with some similar symptoms. And the interesting thing is, they're testing positive still. And I just don't know necessarily, is this a new active coronavirus infection, or are we just seeing kind of dead viruses floating around in their bloodstream and that's reacting? But will there be a second wave? Anthony Fauci says we haven't gotten out of the first wave yet. You know, depends on the day, but most times I do think that we are going to see a second wave this fall, and we should prepare. So one of the things that's nice to do is think about what kills our patients with COVID-19, and it's not the infection. And I think this is an important concept. Patients die of COVID-19 secondary to the body's immune response to that infection. This is a little bit a difference, and so the example I picked out was meningitis. Meningitis, bacterial meningitis, physically destroys the central nervous system, and that's how the patient dies. COVID-19, it's the patient's immune system and it's the reaction. It's being called the cytokine release syndrome or cytokine storm because it is mediated by cytokines. It's amplified by the immune system. The lungs seem to be the major organ of injury and failure, and it's postulated that actually this cytokine release syndrome was a leading cause of death in the 1918 pandemic, which killed some 50 to 100 million people worldwide. As the disease advances, we see such things as lymphopenia, low T cell counts, and a surge in all of these various horrible markers. Things I don't know about you, but I never up until this time tested for ferritin levels, and now I'm frequently doing it. Procalcitonin, we're familiar with, C-reactive protein, interleukin-6, interleukin-2. I can't get those counts, but we know that those go up, and D-dimer among others. These elevations can help us identify potentially the patient at higher risk for respiratory decompensation, and that eventually leads to death. It has been noted that patients with a high mortality risk have such things as older than 30 years old in men, or postmenopausal in women. What's interesting about that fact is this is when testosterone levels tend to naturally go down, and lower testosterone levels are associated with higher than normal elevations in IL-6 and a greater incidence of diabetes and obesity. Are these associations or causality? I don't really know, but again, we begin to mark patients who are potentially at risk. And just to summarize, patients at risk for respiratory decompensation in adults, they're older, greater than 60 years old, they're heavier, and they have the various comorbidities that we'd expect: diabetes, heart, lung, kidney, or immunocompromised. In children, it is the younger children who are at greater risk, and those with, again, various different chronic diseases. And later on, there's going to be an excellent presentation on the pediatric response to COVID, and I think that's going to be a very important lecture. Kids with chronic lung, neuromuscular, immunocompromising kidney disease are all at risk for this respiratory decompensation with COVID infections. So what are some of the other predictors? Interestingly enough, COVID-19 is prominently associated with venous thromboembolus. And that could be one source of the decompensation that we see in the emergency department. In other words, they're starting to clot off with microthrombi, decrease perfusion to various organs like kidney, liver, lung, and heart, as well as a higher propensity for pulmonary emboli. This COVID-associated coagulopathy, or CAC, is a great area of interest, particularly now that we are seeing patients coming back after being previously admitted with a COVID infection. In fact, data from Middledorf shows when they looked at patients in both the ICU and floor, by 1 week out, 10% of these patients had evidence of VTE, and by 3 weeks, a quarter of the patients had evidence of a VTE. So I have had at least now 4 patients who have had COVID infections, came back with similar symptoms approximately 2 to 3 weeks later, and these 4 patients that I'm thinking about all had significant pulmonary emboli. So suggested predictors of this, and therefore the potential need for intubation, might include an elevated D-dimer that's more marked. All of those patients who had PEs had D-dimers over 10,000. Those are some pretty high numbers. Fibrinogen and platelets are typically normal, indicating that this is not a DIC picture. This is a unique contribution of the virus activating the the thrombosis system and microthrombi. Some increases in PT and PTT, not particularly relevant, but sustained elevation of D-dimer, and we are now seeing patients who are coming back, and you might have that information. And if you see that their D-dimer is rising or being sustained, that's a patient at high risk for pulmonary embolus and a very high risk for eventual intubation. One of the other fascinating things is it seems that there's data that your blood type A puts you at greater risk for respiratory decompensation with COVID-19, and this was published in mid-June. There's various different genes. I'm not sure how I apply this information, but I do know that maybe at some point in time this might elevate to some sort of scoring system. We also know that the COVID-19 infection, again, This seems to be a unique property of this particular virus. Upregulates platelet hyperactivity. In a recent report in Blood, they found that platelet gene expression and hyperactivity was tended to increase platelet to platelet and platelet to leukocyte interactions, again, contributing to a hypercoagulable state, which will eventually get the lung, and the lung seems to be uniquely the target organ for this. This was more prominent and severe with patients with COVID infection and felt an increase in organ failure and mortality. Again, pointing to a group of patients at high risk for respiratory decompensation. I just wanted to throw out a very quick summary, and I'm not going to go into this, of the 7 Ps of RSI. Preparation, pre-oxygenation, pre-treatment, positioning the patient, paralysis with induction, place your tube, prove that it's in the right place, and post-intubation management is extremely, extremely important. Pre-oxygenating patients. This is probably one of the most critical endeavors that you can do in preparing the patient for the intubation. It will also identify the patient who needs to be intubated. What you're going to see is the patient goes from 2 liters of nasal oxygen to 6 liters to a non-rebreather plus a nasal cannula, maybe to CPAP, and then you're eventually bagging them until you get ready to intubate them. High flow nasal cannulas have been used. CPAP has been shown to be very effective. We have BiPAP at Beaumont Hospital, and unfortunately BiPAP, for some reason physically, it's really difficult to create a closed system, so we're not using much in the way of BiPAP because, again, we don't want to splatter the virus all over things. But increasing oxygen requirements almost always heralds the need for intubation. I just want to briefly mention, we need to protect ourselves. This is extremely important, and I'm particularly worried now. We are now seeing patients who are COVID positive for things we never expected them to be COVID, like ankle sprains or lacerations, things like that, and they are testing positive. And I'm worried about our lack of PPE in seeing these patients and whether they're placing ourselves at risk. But again, at Beaumont Hospital, we advocate a double layer and double gloving system. Intubation equipment is to a large extent what we usually use for rapid sequence intubation. We want to sedate. The drugs that I would suggest are etomidate, ketamine, propofol, and midazolam. One of the problems with propofol is the induction dose tends to drop their pressure, so you need to be a little bit careful. I would say in most patients I'm using etomidate, and for those patients who are hypotensive, I really like ketamine. Paralysis, keep it simple. 2 agents, a direct acting succinylcholine and an indirect acting, and I recommend rocuronium. Lidocaine, optional. Intubation equipment, this is the place where direct laryngoscopy does not have a place. Video laryngoscopy is really the way to go, and again, this is protecting ourselves. Stylets, endotracheal tubes, and this is a tube clamp. It's very inexpensive. It's just basically a hemostat. And I think that this is important. And I'm going to talk about the tube clamp in a minute, but this is what it looks like. And of course, I have one on me. Bag valve mask and viral filter entitled to CO2. Goal is intubation with minimal exposure to secretions. So meticulous oxygenation, so you have good pre-oxygenation. What is the pre-oxygenation doing? It's removing the nitrogen that is about 80% of what the air we breathe in to give the lungs filled with oxygen and to have the patient not desaturate while we're getting them intubated. And in the COVID lung and the COVID patient, this is extremely important. So sequence as usual. You induce and paralyze once the patient is nicely paralyzed, and wait until your paralytic has fully paralyzed the patient. Don't try to go too early. Again, we are trying to minimize the spread of secretions. One of the things that we tend to do is we push our induction agent, we flush it into the IV, we let it wait for a minute, maybe two, so that the patient is now pretty sedated, and then we paralyze them, we flush it. I am not doing that. I'm really crashing these patients down. I'm giving them a rapid induction agent. I'm actually flushing that with my paralytic, and then I flush things again to get them in. And continued sedation is extremely important. Do not let these patients wake up. And I would say maybe 25%, I'm reparalyzing them. My continued sedation protocol involves both fentanyl for the analgesic effect and the discomfort of being intubated, and either propofol or dexmedetomidine or Precedex. I'm using a lot more dexmedetomidine than propofol on these patients. I find that I get less hypotension, but that is just anecdotal. The sequence: your glide scope is inserted, the stylet is removed, and that's when you clamp the patient. As soon as that stylet comes out, clamp the endotracheal tube. Secretions can't get out. Put your bag valve mask on with your end-tidal CO2, unclamp, bag the patient, verify the fact that your end-tidal CO2 changes color, the tube fogs, the patient's chest is rising, and their pulse ox is staying stable. I do not encourage in COVID patients listening to the lungs. It just contaminates another piece of equipment. Most emergency departments do not have a sufficient number of disposable stethoscopes, so I'm using my own stethoscope. And you know what? It hangs around my neck, and frankly, I don't need to do it. I check the depth with looking at how deep I have the tube and a chest x-ray. So once the patient is bagged, the tube is secured, I reclamp the tube, bag valve mask off, ventilator on, unclamp, and now you can set your ventilator. Continued sedation, we've already mentioned. Steroids. There's a lot of differing opinions. The marked inflammatory surge that is associated with COVID, there's a lot of experts who are recommending steroids, and I'm going to talk about the dexamethasone study in England a little bit later, but a lot of people are advocating a dose of hydrocortisone. If you've gotten to the point where you're intubating the patient, it's probably time to give them steroids as well. Prone positioning. I personally have not proned anybody that I've intubated. But this has shown remarkable benefit in patients who remain hypoxic despite ventilators, and I see it done a lot in the ICU. In an interesting study, 29 patients, 25 of them underwent prone positioning prior to intubation to see if they could improve oxygenation in patients and stave off intubation. Because if at all possible, you want to try not to intubate these patients. And interestingly enough, 19 of them boosted their SpO2 greater than 95%. And of the 6 of them who didn't go above 95%, 5 of those were intubated. That's fairly successful, and it might suggest that prone positioning might be a way to try to avoid intubating these patients, and another adjunct to the oxygen supplementation that we are trying to give them. Before you kind of jump on this bandwagon, obviously the data is soft, there's multiple co-finders, and there's also a suggestion that instead of placing the patient prone, you might get the same result by just sitting the patient up. I definitely can see that as patients are laid down, they have a greater difficulty breathing, and sitting them bolt upright can be very helpful in patients and getting them to breathe a little bit better. I want to talk about the COVID lung, because we need to think about that, because now once we've got the patient intubated, you've got to ventilate those patients. We know that the coronavirus presents with patient in florid respiratory failure, but it seems to be different than what we usually see. Some experts actually say don't intubate the patient because the mortality has been as high as 80% in intubated patients in some cohorts, particularly the early literature. My own personal opinion, that just identified a group of patients who are very sick, and I think that that's an association, not causality. There's a lot of physiologic factors that are going against the patient: microthromboses, sepsis, perfusion abnormalities that contribute to the high mortality. And then, just to make it all that more fun, a lot of these patients go into AKI. Once we have the patient on the vent, now what do? Chest x-ray, the pneumonia looks very similar to what we see in ARDS. It's inflammatory, infiltrates, the lung is edematous, it's inefficient, oxygenation is difficult, alveoli are filled with fluid. However, one of the things that is found is that lung compliance, instead of being low and the lung stiff and recruitment being a real challenge, there are some patients where the compliance is excellent, air goes in and out pretty efficiently. We still can't oxygenate the patient, and this might be the patient where PEEP plays a big role. So here's a chest x-ray of a normal patient and a patient with COVID-19. And if you look at it, it's kind of these fluffy little infiltrates kind of spread out from the periphery. This patient on the right, chest x-ray doesn't look horrible, but the patient is hypoxic. They have a marked increased work of breathing. They required more oxygen support. This patient went on to be intubated in the emergency department and died 36 hours later, despite pretty advanced care, including ECMO. You know, does this look like the chest x-ray of somebody who's imminent to death? Not necessarily, but there's a lot of other physiologic things going on in the background that are horrible to lung function, and we're going to talk about some of those, and we've touched on them before. This is in 2 patients who are suspected of COVID infections. They both tested positive. Again, this was a time we were using that 6-hour test before the rapid test. And again, you see that kind of peripheral basilar infiltrate that now we're beginning to recognize just at a glance. These are some sicker patients. You can see more advanced infiltrate, and this is just prior to intubation. The person on the right, that's a 30-year-old patient. That's a 30-year-old lung. That's a pretty sick-looking lung. When we do CAT scans, we see a whole lot worse. On the left, you can see progression over several days from the patient going, getting sicker and sicker with COVID, and another patient on the right, again, over several days, and you see how the patient is getting a whole lot sicker. And you see up here, in this patient, while they've got infiltrates, you'll notice a lot of the lung is open and free. This lung right there has good compliance, open alveoli, still can oxygenate the patient. This lung here is a much more ARDS-like lung, hard to ventilate, stiff, and edematous. And we're going to talk about these two because they actually now have nomenclature. Just to touch very briefly on ARDS and what that is, the Berlin criteria, I'm not really going to go into it, except that I want to go down to the P to F ratio, PaO2 to FiO2 ratio. I think this is an important ratio for us to think about, and this basically measures how much oxygen you have to give the patient to achieve a certain PaO2. Obviously, the higher the FiO2 necessary to get a PaO2 that's reasonable, the sicker the patient. And if that ratio is greater than 300, the patient's probably in good shape. Mild, moderate, and severe disease is defined by that ratio being between 200 to 300, 100 to 200, and less than 100. That patient is in real trouble. Again, another chest x-ray. Here's a COVID-19 infection on the left and severe ARDS on the right. You can see how similar looking. And when I looked at these patients initially, I went, aha, they're in ARDS, and let me fall back on my ARDS protocols and ARDS protocol, but they didn't exactly pan out that way. So a number of experts in terms of ventilation have argued about pressure versus volume control. And what that tells me is nobody knows for sure. This is an area of controversy, and you're going to have to decide what you are comfortable doing. If you are very comfortable with volume control, which is the mode most of us use, then go ahead and use it and don't worry about pressure. But if one mode isn't working, I readily switch to the next. It's a very fluid kind of thing. Most intubation patients are intubated for hypoxia, so their FiO2 is starting at 100. If there isn't a big involvement of the lung, in other words, if the patient isn't whited out, I tend to start with high PEEP, 14 to 18, but I do want to use the lowest possible PEEP because I want to be as gentle with the lung, because all I'm doing is buying time with these patients until their lung heals. Many patients are hypertensive, but not always. I always have push dose pressors available, and pressor infusions are very common because I know that given the AKI that's associated with this, most patients are not going to need a lot of fluid, and you don't want to give them a lot of fluid. Keeping the patients deeply sedated and sometimes reparalyzed can be very important in synchronizing them with the vent. Typical vent settings that I will use for COVID patients, a tidal volume between 6 and 8, which is normal, pressure control mode, or a volume control mode, but I'm using pressure control a little bit more. FiO2, PEEP, 16 to 18 and a rate of 14 to 16. And the next thing I look at is plateau pressure. Am I overpressurizing the lung? I want the plateau pressure less than 30. I want a minute volume. This is very important to calculate, and all you have to do is ask your respiratory therapist, please give me a minute volume. In pressure control, because you don't control the tidal volume, you need to be watching minute volume, and you want 6 to 7 liters. I want a flow time curve to avoid auto PEEP. In other words, I don't want the patient starting to inhale before they fully exhaled the previous breath. ABG sooner than later. Look at your chest x-ray for depth and what your lungs look like, and consider prone positioning, though that's not something I've done very often in the emergency department. In fact, I haven't. Reevaluate the patient. I kind of hear Ron Krohn's voice in the back of my mind and his gravel-like voice when he would stand and tell you, when in doubt, it's okay to examine the patient. Go back and look. Pulse ox, blood pressure, check your plateau pressure again, check your peak pressure again, look at the minute ventilation, and re-look at your ABGs and while you're looking at the patient. I'm going back and seeing these patients very frequently. Keep in mind that small deviations are multiplicative. One of the patients that I lost, and I was unable to resuscitate with COVID, I remember that patient, it was a small decrease in their pulse ox. There was a little bit of a rise in their plateau pressure. There was a mild increase in their respiratory rate. These small changes tend to multiply together to have a major negative impact. It's rarely just a single big thing. It's usually a bunch of small little downturns that get the patient. Just to make it a little bit more complicated, one of the noted experts in the COVID lung is a guy by the name of Gattinoni out of Italy, and interestingly enough, he's now in Germany. He proposed that there were two primary phenotypes based on the interaction of disease severity, host response, and the ventilatory response to hypoxia. He termed these type L and type H. Type L is that patient with just a few infiltrates. Their compliance is good, so they have a low elastance, they have a low P to F ratio, they have a low lung weight, the lung hasn't gotten real edematous, and low recruitability, despite the fact that you still can't oxygenate the patient. This contrasts usually what comes later, and this is more like our typical ARDS patient. The lung is stiff, it's high lung weight, it's edematous, there's a high right to left shunt, and alveoli are filled with fluid, and there's a lot to recruit. This type patient needs a very different ventilatory protocol than the type L patient. I had an opportunity to do a webinar with Dr. Gadanoni, and he's kind of a fascinating guy. In his experience, over 60% of his COVID patients had this unique type L phenotype of their lung and did not respond to the very typical type of ventilatory strategies that we have used in the past, looking at the lung and saying, aha, I'm in an ARDS situation. And if you can remember back to that slide where I put up the COVID lung and the ARDS lung, and they really look very, very similar. So what he proposes is you get the infection, the virus binds to the cell membrane at the ACE and ACE2 receptors, and that's that spike protein. It causes an inflammatory reaction, which causes interstitial edema within the lung, and that's where you see the ground glass opacities that start in the periphery. The lung is still primarily air with just a few areas of edema at the periphery, and the lung mechanics are still excellent. What then happens is what he terms lung vasoplegia. The lung is one of the most highly regulated organs in the body in terms of where blood flows. And if the lung loses that ability, lung mechanics and lung efficiency go to hell in a handbasket very, very quickly. And what Gadanoni proposes is that the coronavirus binds to the ACE2 receptor. That upsets the balance between angiotensin 1 and 2. You get increased nitric oxide, increased GMP, and what is the end result? You get vasodilatation, increased edema, increased right to left shunt, and the lung can't adjust its blood flow. And now lung mechanics are going badly. For Dr. Gadanoni, he emphasized the work of breathing as a key clinical parameter. He's doing weird things, and I'll show it a little bit later, of shoving manometers down esophaguses and measuring intrathoracic pressure and putting EMG leads on the chest wall and looking at the effort of breathing. I don't have that stuff. But what I can see is with worsening perfusion, worsening right-left shunt, I get an increased work of breathing. And what this feels like for the patient is the patient feels hypoxic. So their respiratory rate goes up. They're using their accessory muscles just a little bit more. They're visibly more uncomfortable. They're trying to take a deeper breath. Their body says, get a tidal volume of 600 cc's, but their lung mechanics are such that they can only get 400 cc's into their lung. So they feel a little bit more dyspneic. So they work a little bit harder. They breathe a little bit stronger. They use their accessory muscles. Their respiratory rate goes up, and they visibly start to look more distressed. Now things start to deteriorate, because what happens is they get increased negative pressure within their chest. That decreases, that increased interthoracic pressure decreases venous lung returns to the right side of the heart, and cardiac output of the heart now starts to plummet. And just at the time that the lung needs more blood going to it, it's getting less blood. And now you're getting a positive feedback loop with all the inflammation, and the patient is going to die on you relatively quickly. How we break up this process, I don't have all the answers, but it is what we're faced with. Other factors, you get a marked increase in metabolic demand at a time when the body can't meet it. We've talked about the thrombosis. Renal failure and AKI play a role, so fluids is not going to be the answer. We see this marked inflammatory elevation that can help guide antibiotics and steroid use, but that's not firmly delineated. And we know from sepsis data that certain patients are predisposed to a massive hyperinflammatory response. I watched a very young woman relatively early back in March literally die within a half an hour of coming into the emergency department. And I think she was one of these genetically predisposed, massive hyperinflammatory response type of patients, and we can do little about that. Dr. Gadanoni says to characterize your type L to type H lung, CAT scan of the chest is really helpful. I have a super low threshold. Not only am I looking for pulmonary emboli, I want to get a better idea of what the infiltrates look at. Look at the work of breathing. I can't do esophageal pressures and I can't get chest wall EMGs like he can, but I can look at the patient. And this is kind of contrasting the two patients. On the left is the type L lung. You can see that it's primarily open. Don't be lulled into a kind of feeling that things are going well on the patient on the left. Despite the fact that the CAT scan doesn't look so bad, this patient was definitely hypoxic and having difficulty breathing. The type H patient is more on the right, and that's very much the heavier, wetter, more edematous lung that we're used to with ARDS. And the patient can go from one to the other. This is a CAT scans on 3 different days in a patient, and you can see on day 1, they go from a type L to a type H patient, and your ventilatory strategy on day 3 is going to be markedly different than on day 1. We're usually faced with day 1, but still we may be seeing patients, more day 3, and you're going to treat those patients and your vent strategies are going to be different. So settings for Dr. Gattinoni for the type L lung that's more compliant with open alveoli. Little higher end tidal volume of the 6 to 8, he's going with 8. He's using a volume control. I totally endorse that. FiO2, usually at around 100%. You want to keep the pulse ox over 92%. Respiratory rate of 14. He's starting the PEEP low and moving up as needed, with 15 centimeters of water being his ceiling. For the type H lung with greater infiltrates and heavier, he's starting the tidal volume lower, 6 cc's per kilogram ideal body weight, FiO2 to keep the pulse ox greater than only 92%. That's my goal. A respiratory rate to keep the PCO2 less than 60. He's accepting some respiratory acidosis and trying to keep the PEEP less than 15 centimeters of water if possible. I tend to go higher than that because I'm using an ARDS net calculation for my type H patients. I'm a little bit more aggressive with PEEP than Dr. Gattinoni. However, he has vastly more experience than I do. And this is that ARDSNet calculus looking at the FiO2 and PEEP. If you can get away with an FiO2 of only 30%, you probably only need 5 centimeters of water. But if you're up around 100%, at least the ARDSNet recommendations are PEEPs between 22 and 24. Dexamethasone. Interesting study, the recovery trial that was just, actually, I think the actual study has been published, but this is just a prelim data. And basically what they showed was giving patients 6 milligrams of dexamethasone at the time of their presentation, and then for 10 more days, they reduced mortality by 1/3 in ventilated patients, by 1/5 in patients who required more aggressive oxygen support, and it showed no benefit for patients, COVID patients, who did not require ventilatory support. That is a number needed to treat of 10. And in Horby's words, Peter Horby, who was one of the directors of this study, dexamethasone is the first drug to be shown to improve survival in COVID-19, an extremely welcome result, and I agree. So I'm switching from hydrocortisone in my ventilated patients to dexamethasone 6 milligrams. Other therapies, well, confusion reigns. There is what is called the MATH Plus protocol. I don't know if anybody has come across it, but it's been like a real media show. They have their own, I don't know, social media area. It's generated a huge controversy of physicians who say, look, this pandemic is such that we've got to broom away all these need to do randomized controlled studies that are going to take years to do. We need data. right away. And the MAP plus protocol is methylprednisolone. Most people are substituting dexamethasone for that, ascorbic acid, thiamine, and heparin, and the plus for additional therapies like vitamin D, zinc, and melatonin, all designed to reduce the inflammatory cytokine storm. And it has this group of physicians really advocating this and saying, look, we just can't wait for data. The water gets muddied when Congress gets a hold of it. Dr. Corey testified before Homeland Security on his personal experience with this protocol, and that got a lot of news to the point where some of the senators were saying to make this protocol mandatory in COVID patients. They now have their own website that you can contribute to. Proponents suggest substituting the dexamethasone. At least the thing I gotta say is the protocol doesn't involve hugely expensive drugs like we are, remdesivir and things like that. There are a lot of physicians who say there are real ethical questions involving both the slow process of randomized trials and the ethics of a control group that we would need, as well as the time. And I would point to you, hydroxychloroquine, first we advocated it, certainly it got presidential approval, and now most of the data, in fact, all of the data has shown that hydroxychloroquine does not seem to offer any benefit except in the minds of a few people out on the fringes. So just to very quickly summarize, this is an area of rapid change. You're going to have to keep up with it. You have to understand some of the pathophysiology that allows these patients. Oxygenation with the various things that we're used to using. Beware of the patient who is requiring increasing oxygen. Intubation stresses the avoidance of splattering secretions. Have something like a clamp to help that with. The pathophysiology involves a unique response that interferes with the ability of the lung to maintain perfusion. Sorry, folks. And high intrathoracic pressure just worsens perfusion both within the lung and other organs. Deterioration tends to occur quickly. Watch these patients, watch these patients, watch these patients. Sorry. Dr. Gadnoni proposes two types of physiology, L and H, and we've kind of gone over that, and the work of breathing is a definite clinical parameter that you can follow. Basically, what we are doing is keep in mind, these patients are intubated for huge time. Patience is likely the best we have to offer because the ventilator is a support measure while we wait for the patient's body to recover. In summary, stay safe. Keep yourself well, just like we talked about. Cherish those who you work. Tell them that you love them. We don't say that enough. We have been called the heroes, and that's exactly the fact. While other people ran away, and rightly so, that's not in our DNA. We ran towards the pandemic as opposed to everybody else, and there's great grace and courage in that, and I applaud each and every one of you. This is just a reference of our intubation protocol, and Winston, who's asleep right next to me, he's the official mascot of MCEP. We both say, stay well, be vigilant, be careful out there. And with that, I'll take any questions. And that's my email. You don't have to capitalize the B in Beaumont. And if you have questions, please email me. And with that, Abby, Teresa, and Jeff, I'll turn it back to you guys.
So let's get a few questions. First off, are there any questions from the chat side? So I have a couple. There's a poll that'll go on in the corner meanwhile. So my question for you, Brad, I think you alluded to this. There's been a debate about, and I got this going in the chat side, about intubating early versus intubating late. For example, let's say
Great question.
they have a high oxygen demand, they're on a non-rebreather, but they're doing okay. They can talk to you, they're maintaining okay. At your institution, are you tubing early or tubing late?
Initially, I was tubing early because my experience with patients who needed to be intubated was tube them early before it is a crash intubation. I have revised that with the COVID patient. I am trying not to intubate them if at all possible. So I am using increasing oxygen, non-rebreather plus a nasal cannula seems to be very, very helpful. And again, keeps the patients in a relatively closed system with viral filters. I'm sitting them prone upright, and at times I'm putting their legs over the side of the bed, and that helps with lung mechanics. But I am watching those patients. I am hovering over them because what I've seen is that they take that final step off the cliff in a matter of a couple of minutes. They look like they're doing well. They're actually kind of, watching television, not exactly talking with their family. Their respiratory rate is stabilized out at around 25, and they're oxygenating between 90 and 92%, and their work of breathing is pretty decent, but it's holding. And then all of a sudden, the nurse is saying, Dr. Walters, you better get here fast because this patient's crumping and I'm intubating them. So one of the things I do try to do is I try to prep for intubation. I get the difficult airway card over there. I, get all my gowns in my mind. I look at everybody. When I look at a person, I'm just walking down the street. I go, okay, I know how to intubate that person. Oh yeah, I know that person's an 8 tube. That person's a 7.5 tube. It's a dark way of looking at life, but that's the way I do it. And I'm looking at all these patients on how I need to intubate. When they're crashing is not the time to start contemplating, could this patient have a difficult airway or not? You want to do that well beforehand.
Awesome. Another question I had for you is a lot of our shops have seen these fancy homemade boxes. It was very kind. People would drop off these plexiglass boxes to intubate in. And I actually have never intubated in one. I decided it wasn't for me. But what's your opinion about these intubating boxes or the intubating drop cloths that have shown up?
You know what? To be honest, I found that the double gowning protocol, I wear an N100 mask and I have a face mask over that. It gets hot pretty quickly under there. And by clamping the tube, I think that it gives me more options. I found it difficult and cramped using one of these boxes. Now, I didn't intubate a patient. I was intubating a mannequin down in my office. Somebody dropped off one of these boxes. I found it hard to manipulate the endotracheal tube. The only thing that I think these boxes really help is they're fast. They're faster than getting into 2 gowns and 2 gloves and kind of that whole dance. You basically just slam the thing over the patient's head and you're ready to go. So it has that advantage. I've talked to people who have these, and universally, they're sitting in the corner gathering dust right now.
All right, do we have any other questions for Dr. Walters?
I have a question. So when you're proning patients, how much, and I didn't hear it in the study that you talked about, how much of an increase in their oxygen and their SAP are you seeing with
So
proning?
these were all patients who had desaturated on supplemental oxygen below 92%.
Okay.
There were 26 patients, 19 of them, by proning them and keeping them on their supplemental oxygenation, were able to increase their pulse ox to greater than 95%. And all of those 19 patients did not get intubated. There were 6 patients that they were unable to get their pulse ox above 95%. 5 of those 6 patients even despite proning, went on to get intubated, and one, they just kind of hovered over the patient and they stabilized out and did not get intubated. So 19 out of 26 patients improved their oxygenation. So that's pretty good. I found that sitting the patients up definitely improves their ability to oxygenate. The nurses want to lie them down. Sometimes the patients want to. I'm constantly getting them up. And the next thing I would try to do is try to prone the patient if at all possible. What I didn't get from this article is how many obese patients they were dealing with, and those tend to be the patients who go downhill fairly rapidly.
Yeah, I feel like 92%, like some of those actually, if you can prone them and they can improve, they can go home. Those don't necessarily need to be admitted at the height, but like, how about the patients who are in the mid 80s? Did they improve enough with proning to not intubate?
No, I don't have enough experience with it, but some of the people that I've talked to said, yeah, I've had patients in the mid 80s who came up to 91, 92%, and their work of breathing decreased. And you know what? That was good enough to keep them from getting intubated.
All right, thank you.
I don't like proning patients who are already intubated. I'm fearful of losing the tube. And one of the things that I do is I disconnect them from the vent and I clamp their tube with a tube clamp. I reposition them, head to the side, and then I unclamp and put them back. I haven't done it in the emergency department, but I've done it in the ICU patients when I've been doing rounds.
Your clamping pearl is huge. I'm totally going to take that back to the shop on my next shift. I am not doing that, and that's game changer, I think.
Yeah, and I want to know, please email your experiences with sitting these patients up and proning these patients to see, even patients without COVID, I'm going to try doing that in the patient I'm trying to avoid intubation just to see if it helps. It definitely helps lung mechanics. We know that.
Well, Dr. Walters, thank you so much. This has been a great talk. I really appreciate everything. You kind of brought everything together that I've been reading about recently, so it's been extremely helpful. So thank you again for coming and sharing your time with us today. As always, it's been a pleasure.
Go forth and intubate.
Will do. All right, so a couple things before we get into our next speaker. I'd like to once again thank ProAssurance, and thank you again, thank you again, Brad. But I'd like to thank ProAssurance again for their sponsorship. We are very grateful for their support today and allowing us to offer our CME that we are able to get you for this event. And it's been huge and greatly appreciated. So next we have another shout out for you. Next one is coming from the current president of the American College of Emergency Physicians, Dr. Jaquist.
Greetings from the AMCEP branch offices in Florida. I would much have preferred to be giving this message to you directly from the balcony of the Grand Hotel, but times have changed. First, I want to thank you for everything you have been doing and will continue to do to help emergency medicine in your communities. I hope you're all doing well, and I know at some point in the future we'll be able to meet again in person and talk through the things that we've been doing this year. So I wish you well in your conference, and until we meet again.
Thank you, Dr. Jaquist. All right, next up, I have the immense pleasure of welcoming our next speaker, Dr. David Hansen. Dr. Hansen is a senior emergency medicine resident at my shop at Central Michigan University in Saginaw. Dr. Hansen served 5 years active duty in the Army and deployed to Liberia during the Ebola epidemic. He has a special interest in thoracic ultrasound, playing the bagpipes, and COVID-19. Please welcome Dr. Hansen to share his story about following the developing sonographic findings of COVID-19 in the lungs as the pandemic unfolded. Welcome to the floor, Dr. Hansen.
Thank you very much, Dr. Mead. Much appreciated. And thanks everybody for having me. As Dr. Mead said, my name is Dave Hansen, and I'm one of the PGY3s at CMU in Saginaw. and very happy to be with you today. Everything looking okay with my screen there? Okay, good. All right, so I am going to be discussing the use of point-of-care lung ultrasound in the diagnosis and management of COVID-19 patients. This is a topic that's been near and dear to my heart over the past 4 months or so, and I found it to be a very helpful adjunct for me in helping to manage COVID-19 patients and getting them to wherever it is that they need to go. I first became interested in this during my ultrasound elective, and we're very fortunate at CMU to have a really strong ultrasound program. And I was going to do my elective. I was going to fulfill all my graduation requirements. I was going to do a bunch of scans. I wasn't going to work too terribly hard. And then I was going to embark on an amazing vacation to Sicily. So it's almost cute now to look back and think that, yeah, I was planning on going to Italy in March of 2020. But, you know, my wife and I realized that that probably wasn't going to happen. So that was certainly disappointing. But hey, you know, at least I have my ultrasound rotation, right? Well, wrong. It does appear that most of the fun of 2020 has been canceled as of thus far. And I was not able to do my inpatient scans like I had wanted to do. And I was disappointed in that, but certainly understood it's not worth the clinical risk to go around scanning potentially COVID patients, especially this early in the epidemic when our knowledge level was significantly lower than it is now. And my feeling is that, well, that's a bummer, but you know, fortunately, the leadership at my residency came up with a good plan to keep myself and the other displaced residents busy so that we could stay on track for graduation and hopefully get some good out of this difficult situation. So a public health elective was created. And we as a group, we were focusing on ways to spread more information regarding coronavirus to the public, how we were going to help keep healthcare workers safe, and just kind of given a lot of freedom to sculpt whatever our interests were to whatever we wanted to within the elective. And I tried to maintain some aspect of ultrasound within that elective. So I was wondering how exactly I could do that. So I started off first with a literature search, and I tried to get a handle on what was the best data out there in terms of ultrasound in COVID-19 patients. And this was, again, early on, and there wasn't much coming out of America, but there was certainly a lot coming out of China. There was a couple of publications that I found very interesting. The first one came out of Wuhan, China, from Dr. Huang and his colleagues. And essentially what they did is a very simple observational type study where they looked at 20 confirmed COVID patients. They performed a CT scan of the chest on each one of them, in addition to a lung ultrasound, and tried to figure out what the findings were. And they found a pretty uniform set of ultrasonic findings. One of the first ones is they were finding a very ragged, interrupted looking pleura. On that picture where the arrow is there, you can see it there. They were finding that there were B lines throughout the lung field, again, illustrated by those arrows there. And interestingly, they were finding what Dr. Huang referred to as the waterfall sign. Some people also refer to this as the light beam sign, again, by that bottom image with that bright flashing light there. They were finding that almost universal in their COVID patients. In another study, Dr. Peng and his colleagues, they replicated these same findings. Essentially, they're coming up with the same ultrasonic findings. So that to me was very interesting going forward. Following that came the studies out of Italy, because, you know, hey, if I can't go to Italy, the least I can do is review their ultrasound literature, right? I mean, that's almost as good. What was coming out of Italy was out of Dr. Buonsenso and his team, is that they were reporting their ultrasound findings in COVID patients. And again, they were finding the same thing. They were finding that kind of thickened looking ragged, interrupted pleura, the B lines. They were finding what they referred to as the light beam sign, and air bronchogram, small amounts of pleural effusions, skip lesions, that sort of thing. Another team, Dr. Soldati and their team, they came up with a standardized lung protocol to kind of nail down how we were going to approach lung ultrasound in COVID patients, and that's kind of still ongoing. And finally, out of Spain came a live Twitter feed from this gentleman here, Dr. Chen. Dr. Chen was diagnosed with COVID very early, and he was placed in quarantine. And what he did was he actually ultrasounded himself every day with his butterfly and posted the results on Twitter. So we got to watch a live feed over 20, 25 days, however long it was, watching his lungs show the pathological findings of the ragged pleura, the B lines, the light beam sign, and then ultimately result in a normal lung tissue. So that was a pretty cool thing to observe. So I was pretty intrigued by all these findings with the use of ultrasound in COVID, but I wondered, is this specific to COVID, or is this brand spanking new, or is this something that's been around for quite a while? So I did a little bit more digging, and it turns out that the use of lung ultrasound in the diagnosis and management of viral pneumonia has been around for quite a while, because ultimately that's what COVID patients are resulting in, as a viral pneumonia. I looked and found this study that was published in the European Respiratory Journal in 2017 by Dr. Sobe and his colleagues. This was a cross-sectional study, and they looked at the use of ultrasound versus chest X-ray versus CT scan in the diagnosis of viral pneumonia patients. And it was found, their findings were that ultrasound was actually quite sensitive, specific, and accurate in the diagnosis of viral pneumonia. CT scan was as well. CT scan numbers in terms of sensitivity and specificity were actually quite similar to ultrasound, but they found that chest X-ray is not particularly good. It's not sensitive, it's certainly not specific, and it's not particularly accurate either. I found another meta-analysis that was actually published in 2017 in Medicine. This was by Dr. Long and his colleagues. And they did a meta-analysis and looked at about 12 different articles with a patient pool of over 1,500. And specifically, they're looking at the use, again, of ultrasound versus chest X-ray versus CT scan in viral pneumonia patients. What they were finding is that ultrasound actually has quite a high sensitivity of 86% in specificity of 88% in viral pneumonia patients. Again, chest X-ray not particularly good in these patients. CT scan and ultrasound essentially comparable in their sensitivity and specificity. I also found this study. This is actually a much more recent one. This was published in May of 2020, and it's dealing specifically with chest X-ray and actually in urgent care centers throughout New York City. Now, it's almost reflex that we get chest X-rays when people come in with respiratory complaints, and even if we're concerned about COVID, we tend to get chest X-ray too. I'm not saying there's anything wrong with it, but this particular study, excuse me, looked at 636 chest X-rays in COVID-19 confirmed patients and had them reread by a team of radiologists. Now, interestingly, they did not blind the radiologists to the positive COVID finding. And after the rereads, they found they basically stratified the results into normal X-ray, and then if there was pathology, the severity of pathology ranging from mild, moderate to severe disease. They found in 58.3% of COVID confirmed patients, they had normal chest X-rays. So, you know, that kind of nailed it home for me that I can't rely just on chest X-ray if I'm going to be managing COVID patients. Now, what about CT scan? Because, you know, in the emergency department, we love our CT, and there certainly is findings on CT scan in COVID patients. And Dr. Walters kind of touched upon this a little bit more extensively than I will. But in this background slide here, you can clearly see the ground glass opacities and the bilateral lung fields that we see in COVID patients. We know about this, and CT is a great imaging modality, no doubt about it. We get great images, their quality, but their CT has its own problems too. It is an increased cost, and there is radiation exposure to the patient, of course. There's also potential exposure to the radiation techs, to the people in the hallway, other patients, because you're going to have to wheel these people to the CT suite. So that's a risk as well. And again, after you get that CT scan of a COVID patient, they're going to have to do a deep clean of that CT suite, which is going to grind the rest of your emergency department flow to a halt. So why specifically should we be doing ultrasound on these COVID patients? Well, we just kind of touched upon all of that. Chest X-ray, not particularly good. It does take time, it's low sensitivity, and you are going to have to clean that portable machine afterwards. CT, yep, you get great images, it's highly sensitive, but again, it takes longer. There's more cost involved, there's radiation involved, and again, they're going to have to do that deep clean. Now compare that with ultrasound. Now you're going to do an ultrasound at the bedside, you're going to get your results immediately. They're highly sensitive, and granted that is somewhat operator dependent, but we're going to get to the protocol in a little bit, but it's the type of thing that I think if people practice with a little bit, they can get quite good at quite quickly. You are going to have to clean the machine, and that is going to take a little bit of time, but again, we're going to get that done a lot quicker than the portable or certainly the deep clean of the CT suite. So here's what we do in the Covenant emergency department. I was sold on the idea that I was going to ultrasound just about as many people as I could. My elective ended and I went back to work in the emergency department, and my very first shift was in our Covenant COVID corner. And I figured I was going to have plenty of opportunity to do a lot of different scans. So I had to account for a few logistics first. First and foremost being my own personal protective equipment. We are very fortunate at Covenant that we had PPE available, and I felt safe in going into a patient's room with my PPE. Next came the care of the machine itself, because the last thing I'd want to do is bring the ultrasound machine in to see a patient, end up bringing it to another room, contaminating or possibly affecting that patient. So I looked into the manufacturer's recommendations for cleaning of it, and it turns out that the good old-fashioned AF3 gray wipes are perfect for cleaning the ultrasound machine. They're safe to use on the machine itself. It kills the virus. You just have to be a little bit fastidious in how much you clean it. Now, to prepare for this, we made this little infographic and hung it up around in our emergency department. One of the things we did to help prepare the machine is we actually removed the baskets, which we would use to put angiocaths in and more ultrasound gel in, and hopefully we can find those baskets. I think Dr. Mead knows where they are, but we'll see. But they were potentially a spot for fomites that was going to make it a little bit more difficult for us to clean the machine, so we decided they had to go. And then, unfortunately, what had to go was those bottles of ultrasound gel. We're just going to use the packets because, again, we don't want to be carrying infection from room to room. Before every scan, we're going to clean the entire machine with the AF3 wipes, and after every scan, you're going to clean it with the AF3 wipes as well. So we basically, I was ready to go, and I wondered, what my first step was, and one of my attending physicians suggested, hey, why don't you go up to the ICU and to the COVID ward and all the intubated patients and just start scanning them? And my first thought was, okay, buddy, sounds good. You first, I'll meet you up there. And then the second one is obviously, there's an ethical dilemma here. The patient can't consent to the study. I'm not on the treatment team. And ultimately, what would be the good outside of my own practice? Because that patient they already have a disposition. They're in the ICU intubated. So I also figured that I was going to get plenty of experience in scanning COVID patients while I was at the Covenant COVID corner. But then finally, the question is which patients am I going to be scanning? Okay, so Dr. Mead and I kind of worked through this, and we came up with some kind of loose guidelines that we were going to follow. And if a patient has fever, shortness of breath, with a cough, and but they're not requiring any supplemental oxygen, they're able to walk around the room, it's really not worthwhile ultrasounding this patient. I mean, this patient's going to go home. If we ultrasound them, we're just going to risk contaminating the machine. It's going to be prolonged exposure to a COVID patient. It's not really going to be too high yield for us. So maybe that's a patient that we don't ultrasound. Now, on the other hand, if the patient has fever, shortness of breath, cough, and is tachypnic, but they're not really requiring supplemental oxygen at this point, but maybe they're really chugging a little bit, and you're just not quite sure as to whether this patient needs to come in at least for observation, or maybe they can go home. This is a perfect candidate for somebody to ultrasound. And then depending on what you find on that ultrasound, that can help you arrange the disposition. Akin to that, let's say that the patient has shortness of breath, cough, requiring oxygen, and they're going to get admitted, but you're just not quite sure about the disposition on this patient. Maybe they need to be go to the floor, maybe they need moderate care, maybe they need ICU. You're not quite sure. Again, this ultrasound is a great method of developing more data that can help you to make that decision. Now, the patient's going to the ICU, they're intubated, they're hypoxic on a PEEP of 18. There's no point in ultrasounding at this point. They know where they're going. It's just going to be more exposure. So you want to choose your patients carefully. Don't risk contamination of the machine or yourself just because you want to do a scan, okay? So those italicized in green patients, those are the ones that are going to be your prime patients for performing an ultrasound on. So in terms of a scanning protocol, I had mentioned before that Dr. Soldati and his team had come up with this principle that they wanted, or this protocol that they wanted to do to affect the entire lung fields. And that's really important because what we're seeing in COVID patients is that we're seeing skip lesions, meaning that Within one intercostal space, the ultrasound might be completely normal. You go a couple more intercostal spaces away and you're going to find pathology. This isn't a big bacterial pneumonia with a huge consolidation and it's just going to basically be taking over the entire lobe. It kind of comes and goes, you know. So it's important that you get a full coverage of the lung. We're finding mostly that COVID is affecting the periphery of the lungs first. So it's tailor-made for ultrasound because we put the probe down, there's the patient, there's the pathology. We're looking for extremes here. We're looking for things that we can say without doubt, yeah, this is positive or negative. And we want to, again, cover as much ground as possible. Dr. Soldati, they're proposing a somewhat complicated protocol where the lung fields would be divided up into 14 discrete areas, and that each of those 14 areas would be scored on a basis of 0 to 3, with 0 being completely normal lung tissue, 3 being totally consolidated, B lines, ragged pleura, air bronchograms, things of that nature. It would all be added up and put into a database, and we would track that database, and it would help to promote ultrasound use in COVID patients. It would aid in telemedicine and help people, with ultrasound patients in places far away. And I think that's all a great idea. And this is the anatomical map that they were using. But personally, I try to keep things as simple as possible. And instead of 14 lung fields, I like to think of just 6, essentially anterior, posterior, and lateral, bilateral lung fields. Okay, you want to scan with the curvilinear probe. If you do need a little bit better detail of the pleural line, you can certainly switch to the linear probe for it, but the curvilinear probe is going to get you the deepest penetration, and it should be your go-to for this. And then what you want to do is hold the probe with the marker cephalad, and you want to move back and forth through each intercostal space almost like you were mowing a lawn. And I like to think of the lawnmower as I do this because I want to hit every single intercostal space and cover the entire lung field. If I find something that I want to get a better look at, I will then rotate the probe to the anatomical view, and I will see what I can see at that point, save images, and kind of bear in mind what I'm finding here. Of all the areas that we're finding the most consistent pathological finding, it's going to be the posterior inferior. In practically every study that I've read thus far, you're most likely to find pathology in that posterior inferior aspect bilaterally. Doesn't mean you won't find it in the lateral or the anterior, because Lord knows I certainly have, but if you had to put your money on one spot, it would be that posterior inferior aspect. So what exactly are we finding here? Well, this slide here in this image that I have has 2 of the most common images or common pathological findings in COVID patients. The first is that so-called ragged pleura. Now, where that arrow is pointing, kind of a bright line that looks a little bit thick and kind of gnarled and perhaps interrupted, that is the patient's pleural line. In normal lung tissue, it's going to be a thin, bright, continuous white line. Here, that's clearly not the case. This is artifact from inflammation from the disease process. Other findings that you're going to commonly see are the so-called B lines. These are artifacts created by inflammation of the pleura. Kind of appears as a hyperechoic, almost like a light beam flashing downwards. You're going to find these pretty commonly in COVID patients. And I want to spend a little bit of time talking about this light beam sign, because this is kind of an interesting thing that's just kind of recently spoken of regarding COVID patients. If you look at this scan here, you can see where that first arrow is, that pleura. Now, compared to the pleura from the previous slide, this one looks a little bit thinner, a little bit more bright, a little more continuous. This I would consider to be a healthy pleura. But if you look at this bright kind of shining light back down there, it's kind of unusual to see that sort of thing in the presence of a normal pleura and what appears to be normal lung tissue. You can very often see A lines in these patients, which again is just artifact from the pleura, but that's a finding in healthy lung tissue. This was called the light beam sign by Dr. Vapotherm. This was actually published in the Ultrasound Journal in April of 2020. Dr. Vapotherm and his colleagues called it the light beam sign. Dr. Huang was calling it the waterfall sign. But what they were finding is that it was very, very specific in terms of identification of an early COVID patient. So again, this is perfect for that one who is maybe a little short of breath, not quite requiring oxygen just yet, but you ultrasound the lungs, you find those B lines, you find interrupted ragged looking pleura, and you find a light beam sign, maybe that person is going to warrant an observation stay at least. Of course, you'll take a patient by patient basis, but things to bear in mind, okay? So ultimately, what do I use all of this for? I use the ultrasound to help me to dispo the patient. We all know about our conventional tools and the labs and the swabs and a chest x-ray. I think that's an important part of a workup in COVID patient, but you can't necessarily hang your hat on all of that stuff. The focus of the lung is a great tool to add to your toolbox and to help you to ultimately get the patient to wherever it is that they need to go, whether it's home, whether it's the floor, whether it's a higher level of care. So sum up, just remember, choose your patient carefully. You want to cover as much space as possible when you are scanning your patient. And you want to look for those B lines, the ragged pleura, and that light beam sign in order to, as pathological signs that maybe you need to escalate a level of care on this patient. I want to thank you very much for having me today. That's all I have. I'd be happy to take any questions you might have.
All right. Thank you very much, Dr. Hansen, for the update on COVID and ultrasound. Are there any questions first off from the chat group? So looking off to the side. I had one question. So you talked about the the options for keeping the machine clean and whatnot. Did you have were there any challenges with kind of enforcing, keeping the machines clean and using the gray wipes? Because it's always, on a good day, I know it's hard to keep the machine clean in any shop.
Yeah. Yeah, I agree. It is a challenge just to keep the machine clean on a normal day, despite when, we're in a global pandemic. Again, it's just the real challenge was to, get people to try to do the ultrasound, because people can sometimes be a little bit reluctant to try new things. You got to manage patients and people that have habits and practice patterns. I certainly understand that. The real challenge was to get people to clean before they go into the room, because even though, and honestly, I have to remind myself sometimes, and I wrote the infographic, you just have to remind yourself, hey, you don't know where this ultrasound has been, because the ultrasound gets grabbed and brought into the trauma bay, and just there's no time to think about, hygiene of the machine at that point, and who knows what that patient was bringing in. So it's important to clean it beforehand, because the last thing you want is to, make a patient sick. So clean it beforehand. We've browbeaten our people enough that they tend to clean it afterwards. They get a little bit better at least, but really cleaning it beforehand and has been the big challenge I've found.
And you mentioned the findings that you're seeing in COVID-19, the waterfall or light beam artifact. You mentioned the thickened and irregular pleura. Are there any other common findings that you're seeing?
Yeah, we do. There are other findings. One would be the air bronchogram, which I find a little bit difficult personally to recognize. I'm working on it. My feeling is if people are not ultrasounding lungs on a regular basis and they're kind of beginners at it, that things like the B lines and the ragged pleura, those are pretty easy to see. You put the probe on, boom, there it is. Air bronchogram can be a little bit more elusive, and also we're seeing small pleural effusions. Like this is not a CHF patient who's got or somebody with a pleural effusion who's got 1,000 cc's in their pleural space, and it's just fluid there. It's very subtle. And again, because of those skip lesions, you might have a little bit of pleural effusion in one intercostal space, move two away, and you got nothing. But really, it's the air bronchograms and the pleural effusions, the small discontinuous pleural effusions that we're seeing as other common findings.
Awesome. Well, thank you very much, Dr. Hansen. It has been a pleasure to host you at our event. Thank you so much for joining us, and we will see you again next time. So thank you very much. Awesome work today.
Thank you.
All right, I think we have a few announcements from Dr. McGowan.
All right, everybody, just as reminders, those of you, I think there's still a few people that are on cell phone numbers and just have iPad or iPhone on there. Just make sure you guys get your names to us, or at least your phone number, so we can make sure you get your CME credit. And again, the CME emails will be sent out shortly, so just make sure you kind of monitor for that, including your AOA credits and everything as well. Again, we appreciate our Pro Assurance sponsorship. They made it so we could get the CME support for free. Upcoming events and Amazon Smile information is going to be on the little slideshow as we go. And let's give like a 5-minute break or so, and we'll restart about 11:15 or so, so that way people can take a break for the restroom or whatnot as needed, okay? Just make sure everyone stays on mute as we kind of return back. See you shortly. All right, everyone. I know we got a little short break there, I know. Let's get back to it so we can kind of keep on our time here. I'd like to introduce Dr. Pam Coffey. She's actually a fellowship trained pediatric emergency physician. She's actually one of our core faculty at the MSU Sparrow Emergency Medicine residency. She's also a staff physician at Sparrow Hospital in Lansing, Michigan. And again, she's going to bring us one of the hot topics in PDM. Welcome, Pam.
Thank you. Thanks, Jeff. I appreciate that. Can everybody see my screen? Everybody good? Thumbs up? Cool. All right, I'm going to reduce this so I can see and not look at myself while I talk. Okay, so I am going to review what's near and dear to my heart, but I know that with all the stuff going on with COVID, and it came up fairly early on that kids were not that heavily affected. And so we kind of took a little bit of a back seat, but trying to bring everyone back up to speed on where we are with the kids, just so that you have a good background in your pocket, so you know how to handle them. We're going to talk about the history of COVID as it pertains to the population, and then we're really going to get in and talk about the multi-system inflammatory syndrome in children, and why that is probably going to be more relevant this fall. And then I really want to talk a little bit about the pediatric transmissibility, because that is in the news fairly consistently right now. And you're going to get questions from your patients as to whether they should be going to school or not, and whether they got their illness from school, and that the data shows this, data shows that. So I will talk about that towards the end. Oops. Why am I not forwarding? Okay. So basically our history goes all the way back to January of 2020. Long history, a lot of journal articles to go through. Actually, there was quite a bit for 6 months of data, most of them which came out of China. But the most important study actually came from Dong et al. He looked at the first 2,000 cases that were reported to the Chinese CDC. The very first case that they had that was pediatric was on January 16th. But of these 2,000 patients, 700 were confirmed by testing. The rest they assumed were based on exposure and symptoms. There was no difference between girls and boys, so they eliminated the gender gap right away. And then their goal was really to look to see, are kids going to be severe? Are there going to be problems with them? They divided the groups into 5 different subsets based on their symptoms. Asymptomatic, there was basically no symptoms. Mild was essentially a cold, basic URI symptoms. Moderate was pneumonia with fever, but no hypoxia. Severe was fever, hypoxia requiring oxygen support, and then critical put them in the ICU and usually required ventilator support. And as you can see across the age groups, not a lot of difference with the predominant amount of kids in the mild range, basically at all age group. Of the criticals, the kids less than 1 year made up at least half of them. And with this little blip at 11-15, but really only 3 versus 2 at 1 to 5. So not a lot of kids in the critical range, a few more in the severe range, so did require some oxygen support, but the vast majority were in the upper respiratory type infection level. The next study looked at 303 studies that came out over the first 2 months. Most of them were in China, and they excluded all the duplicates. So what was happening is a lot of the hospitals, because their kids weren't the most common patients that they had, they were writing them up as case reports. So there was a ton of duplicate studies that came out, all descriptive, all looking at how these kids presented, but they found 820 cases that were absolutely confirmed to have COVID-19, not just based on their symptoms or their exposures. So a little more concrete data, and again, shows that about 15% of the time, the kids are asymptomatic. If they are symptomatic, they are most likely to have a fever, and then secondarily, most likely to have a cough. So this gave us at least an idea of how they were presenting. They looked at the labs that were ordered. White cells were most often normal. The CRP was elevated a third of the time. And then most of the testing that they were doing at the time was using radiology, which is the same in the adult world. And again, the chest x-rays didn't show it as much. They would confirm with CT scan, but about almost 60% of the time, the kids, just like the adults, had the lower lobe ground glass opacities. In this time frame, they only had 1 confirmed death. It was a 14-year-old male. So the last study in China looked at the pediatric cases specifically in Wuhan. They found 171 of the 1,400 kids that they tested, only 171 tested positive, which is about 12% of the population that was positive of all the kids. So of that same thing, 15% were asymptomatic. Most of the kids, if they were symptomatic, they had fevers and cough. They noted that the kids also had pharyngeal erythema. The prior studies looked at sore throat, not particularly just erythema, and came down with a lower number. So even though they're erythematous, they're not actually complaining that they have that sore throat. The good of this study is we finally started to look at some of the more critical kids, and they had 3 of their patients in Wuhan were treated in the ICU. 2 of the kids had predisposed conditions. 1 had hydronephrosis, and 1 was undergoing chemotherapy for leukemia. But their one death that they had in Wuhan was a 10-month-old male who had intussusception and developed multi-organ failure. Now, they did not elaborate whether they detected the intussusception or the COVID first. So it was uncertain at this time whether they were related or not, but he obviously had other concerns. As the virus transferred over to or spread into Europe, we found studies coming out of Italy looking at their pediatric population. This confident study came out of 17 Italian pediatric emergency departments. And again, all descriptive, all trying to give an idea of how these kids are presenting and what we had to worry about. Their average age or median age was 3.3. What was interesting about this study that they noted is that 55% of the kids that they had in their ED were exposed from patients outside of their own family members, which actually goes against some stuff we're going to talk about with the transmissibility later. Again, 20% asymptomatic, a little higher than what Don got, but using the same criteria. And again, the majority were 58% were mild. Of their patients, they had 9%, this was 100 kids. So 9 patients received oxygen support, and 6 out of 9 had the pre-existing health problems, and they had no deaths reported. So the data kept coming in, again, all descriptive, and as it spread, we got more and more country data, and fairly consistently, kids made up about 2% of the population of the positive cases in all the countries. Spain, interestingly enough, had a 0.8%, but I don't know if you recall, they had their kids on a 40-day lockdown. Their kids were literally not allowed to leave the house. So they had 0 interaction. So their rate as a total was definitely going to be lower just because of that. When it came to the US, we started collecting our own data, and the CDC confirmed they put out their first batch of numbers looking at data from February 2nd to April 2nd, 150,000 cases in the US at that time, and only 2,500 of them were under the age of 18. We fell right in line with the rest of the countries. Again, 73% had fevers and cough. This was actually lower than the 93% of the adults that did. So again, more kids are asymptomatic or mild disease. They only were able to collect 20% of the data in terms of hospitalization status, but of that, 6% were hospitalized, probably in the right range given the other studies, and also given that they knew the hospitalization status because they were actually in the hospital. So versus 10%, which were of the adults, so significantly lower. And by that point, we had 3 pediatric deaths in the US. So at this point, looking at all this data, most pediatricians went on vacation. I'm just kidding, they did not. They all went to telemedicine. But they did relax a little bit. We knew that COVID was not hitting our kids the way it had, which was actually very much a relief given the flu and RSV season we had just come off in most of the country. So we knew we had to watch for fever and cough, and we knew that our very young kids and our kids with coexisting medical conditions were the kids that we had to put the most energy into. A lot of pediatric EDs opened up to adults. We gave up our negative pressure rooms and tried to help out the best we could with the patients who were actually sick. The CDC was able to report that of their 295 kids with COVID, and this was a subset report that they had looking at pre-existing medical conditions, 77% did have 1 or more. Oddly enough, studies that looked at asthma, because initially we thought asthma was going to be our big problem in kids, and that was actually not proving to be true. The most common comorbidities were actually cardiac issues. So a lot of our kids that had congenital hearts, we were a little more worried about them, as well as all of our oncology patients. Looking at the timeline at this point, as I said before, we've got the first case in China on January 20th. The first case in Korea was February 19th. Our first case was March 2nd. We were doing good. The United States was under a state of emergency. We felt the kids were safe. Everything was fine. We only had 1 death by March 24th. And then all of a sudden, we got this release from the United Kingdom. And they tell us that there is now this strange increase in what they called multi-system inflammatory disease. They released their study, and it showed that in this poor little ICU in South London, 8 kids in a 10-day period came in with looked like Kawasaki type disease illness. They all had the symptoms of Kawasaki's, but they all also had GI symptoms, which is not in the algorithm for Kawasaki's, and we'll talk about that in a little bit. All were previously healthy, which was really interesting, is that none of them had had symptoms of COVID, even though the United Kingdom was having the same issues we were having at this point in April. They were all healthy by weight, and they all tested negative on presentation, but 4 gave a history of a significant exposure. All 8 kids progressed to vasogenic shock. None responded to volume, and they all required pressors. 7 out of the 8 were vented not for respiratory issues, but for actual cardiac support, and all of them had elevated markers. They looked at the main ones, the CRP, hydrate, POCAL, ferritin, and all of the markers were elevated in all the children. One of the child developed arrhythmia and shock, was put on ECMO, and he unfortunately died. They released the study not knowing if it was correlated to coronavirus or not. But then a week after they published it, they published an addendum and said that every single kid had tested positive for antibodies. Bergamo, which we know was the epicenter in Italy, also about the same time said, we have suddenly seen more Kawasaki's disease. I thought this was sort of funny. It was for an Italian, very Catholic region, divided the groups into BC and AC, which I think a lot of us are going to think before Corona and after Corona. But they looked at how many kids they'd had in their small town in the 5 years prior, and found that they had 19 patients. In the month and a half from February until April, they had 10 patients. Of these kids, 2 were positive by PCR at the actual time, and 8, including the 2 that were positive by PCR, were positive for antibodies. 2 of their 10 kids were negative both for PCR and antibodies. So sort of interesting information. Not the first time that a coronavirus has been linked to Kawasaki's disease. Back in 2005 in New Haven, Connecticut, Esper described cases. They had 8 out of 11 kids that they had with Kawasaki's over a short period of time were positive for this coronavirus that was spreading at the time. They did a comparative study, and they took 22 kids that were matched age and time that were also had Kawasaki's disease, but they were not positive for the coronavirus. That didn't have Kawasaki's disease, and they were not positive. So somehow out of this correlation, they drew a correlation that the coronavirus, which they now name the New Haven coronavirus, was linked to Kawasaki's disease. Unfortunately, further studies later than that couldn't validate this, because there was a lot of kids with Kawasaki's that did not have the coronavirus. So, but there is some tangential correlation, so it's not impossible. So I want to go over some Kawasaki's disease, because I truly think that as this goes on, we're going to look more of it as Kawasaki's and not necessarily as coronavirus, because there's some variations in the 2 with the MCEP and the Kawasaki. So let's talk about Kawasaki's first, and then we'll get into how it pertains to MCEP. So Kawasaki's first described in Japan in 1967. It's also called the mucocutaneous lymph node syndrome. That's a great board question. It's a vasculitis. We have no idea what causes it. There is some speculation that it's a post-viral, definitely post-infectious something, but only based on the fact that the majority of kids have some URI symptoms in the weeks preceding. However, it tends to be more predominant in the winter, increases through the fall and down through the spring, when there's a whole bunch of other cough, cold, congestions going around. So it's hard to know if there's correlative or not. But the most important part is that it is the leading cause of acquired heart disease in kids in North America. which is not a common issue. So to have one thing that causes most of it is a little more concerning. It is more common in males than female, and it comes in 3 phases. Acute is in the first 2 weeks, then there's the subacute phase in 2 to 4 weeks, and then it resolves in the convalescent phase over 4 to 6 weeks. The criteria, which we all know and we learned for the boards, is fever for greater than or equal to 5 days. If you see a kid on day 4, technically you're not supposed to start the workup until they are febrile for 5 full days. They get a non-purulent bulbar conjunctivitis. So this is a non-draining, non-goopy conjunctivitis. It's just some glossy red. I describe it more as, do their eyes look hazy, hungover, tired, like they haven't slept. They get oropharyngeal erythema, and that context is anything: bright red tongue, bright red throat. They get cracked erythematous lips, anything in the mouth that looks essentially abnormal or inflamed. They get a rash, and this rash is really non-specific. There's no bullous, there's no vesicles, may or may not be palpable. Most of the time it's not. Usually it's hot red, not quite purpuric, not quite petechial, not quite dark enough for that, but just sort of what you would look at and say that looks like a viral rash. The peripheral extremity changes, usually they get swelling, erythema, they get edema. They'll come in and say that their hands and feet hurt. Younger kids won't want to walk because their feet are super tender. And then the biggest criteria that's hard to meet actually is that they're lymphadenopathy, but they have to have one that's about 1.5 centimeters, which is really significant size for a little kid. Some pictures. These are actually the first 2 with the conjunctivitis and the rash are actually from the first case study that was described in the US linking the Kawasaki's with COVID. It was a 6-month-old out of California. And they show the bulbar conjunctivitis, which you can see just the erythema, but no drainage. And then that's a great picture of the rash. I really like this one because that's exactly what it looks like. Just sort of red and irritated, but then their palms are red and swollen as well. And then their strawberry tongue, that's one of the examples of it. You can see the papillae more often, and it's just sort of a beefy red tongue. So those are our 3. That's the only thing I don't have pictured is the cervical lymph nodes, but those are hard to photograph. A complete Kawasaki's, usually we see this in age 1 through 9 years. They have a fever for greater than or equal to 5 days, plus at least 4 out of the 5. So the conjunctivitis rash, as we talked about. The incomplete is a little harder to diagnose. They get a fever, still have the fever for 5 days, but they have 2 out of the 3 of the 5 criteria. Most of the time it's a conjunctivitis and the oral changes. And again, the cervical lymph nodes are the ones that are hardest to get to. But these kids also have lab values that are abnormal. So they'll have a CRP greater than 3 or sed rate greater than 40. And then they'll have greater than or equal to 3 of the following. Either the white cells are elevated, they have anemia, they have elevated platelets, they have low albumin, elevated liver enzymes, or they have white cells in their urine, and this is an aseptic non-bacteria urinalysis. Or if they have an abnormal echocardiogram, then that counts as the incomplete, even if they don't meet it by the other physical findings. The complications are almost primarily cardiac. In the acute phase, you'll see tachycardia, myocarditis, pericarditis. They may have an effusion. You may hear a murmur. So definitely listen in these kids, because if you hear a murmur early on, most likely concerning that they'll evolve into a further cardiac complication. Particularly ask if they've had that murmur before. Most parents do know. And then any kind of arrhythmia that they would have is abnormal. In the subacute phase, this is when the coronary artery aneurysms develop. They can start in the acute, but oftentimes it's in the subacute when they start. So we tend to see the kids in the emergency department in the first acute phase because they're in their first 5 days of fever. But you may have a kid who's had 5 days of a fever, gets diagnosed with something like adenovirus or the flu that lasts 10 days, and they come back in and they're actually saying, yes, I'm on 2 weeks of a fever. Be very diligent with these kids. Make sure you get a good cardiac exam and consider an echo in these kids. If they tell you this fever has been going on for 2 weeks, and they don't have a diagnosis yet, then you'd really have to be concerned with this in these kids. The aneurysms will start, it happens in about 25% of untreated children, and we want that treatment to start in the first 2 weeks. So if you're getting them in the second week, you definitely have a high level of thought that this would be what's going on. We worry that they go on to infarct or at least have ischemic heart disease, and they can present in sudden death. So never a good thing that happens. So identification early is key because treatment early is key. You definitely want the echocardiogram 3 times, once at diagnosis, repeat it during the subacute phase, and then again at 6 weeks after the convalescent phase is over and they have resolution of illness. If by that point they don't have any development of cardiac issues, they're in the clear. They're not going to go on and develop cardiac issues later from this illness. The treatment currently is IVIG, 2 grams per kilo over 12 hours. This causes almost immediate improvement in 90% of patients, and up to 95% of patients prevents their aneurysm from forming. Repeat the dose if the fever does not break within 48 hours. And then these kids go on aspirin. They start with a higher dose and they reduce to a lower dose for 6 to 8 weeks. So that being said, let's go back to COVID and see how it relates. We're now in May. So we know that this illness exists. We know that we've got an inflammatory syndrome circulating that seems to be related to COVID. And the CDC compiled all the data and came up with the basic guideline that says that you must be a patient under 21 years old. There must be a fever. They do not, and they still don't list how long the fever needs to be present. So most of us are not waiting the full 5 days to do the workup. Various institutions have different policies, but some of them will stay within 24 hours, and we'll go over what some of the CHAP one, which has become more of a standard. But fever for at least being present, no definite length of time. And then lab studies that show evidence of inflammation. These are the labs that we're already doing for COVID, but your CRP, your SED rate, your ferritin. And then they want a severe illness requiring hospitalization with multi-system involvement. So that can be greater than 2 organs. So with Kawasaki's, if you have a rash and you have oropharyngeal erythema, you've got 2 systems involved. If you've got a murmur and a rash, there's 2 systems involved. But a lot of these kids that they're finding with the MCEP actually have the GI system involved, which is not typical of Kawasaki's. So if you have a child who's vomiting and has a rash and a fever, at this point, with what's going around, you have to suspect that they have MCEP and you need to evaluate for them. There can be no alternative plausible cause. As we're opening up, we're starting to see some of the vomiting illnesses coming back, and we're also seeing kids playing outside and getting their normal hives. And if they don't have a fever, then it's not part of the syndrome, which neither of those usually cause. And then they need to be either positive for current or have had a recent current infection by testing or exposure within 4 weeks of symptoms starting. That one's a little tough, and that one gets debated in some of the different pathways because we just, as we saw, so many kids are asymptomatic that they haven't been tested. So a lot of times hospitals are testing along with evaluating them for this pathway. So at this point, New York City comes out and says, hey, we've had at least 89 cases of this, and this is in May. Makes sense. This is where we had so many cases in the general population, and now they're seeing this correlation. So the CDC started a study, and they funded it, and they looked at a collaborative effort of MCEP in the United States. The data was collected from 26 states from March 15th to May 20th, and the Michigan data came out of Children's Hospital Michigan and Mott Children's Hospital. Total, they found 186 patients, which is interesting if New York saw 89 of them. They didn't break down the total amount. They just came through and said this is the baseline amount. Boston Children's, because it's a CDC study, put together a phenomenal list of infographics that I'm going to go and report to you now because they did it much better than I could have. But basically, this is where all the states who were reporting from came. As you can see, Michigan and New York and the New York, New Jersey area had the most reported cases that fit with what we were seeing in the United States at the time. Interestingly enough, you can see that the positive cases in our country were going down as MCEP was going up, which goes to the 2 to 3 week lag between the positive infection and then MCEP developing. They, along like what we see with Kawasaki, see a higher predilection in male patients and not a huge gradation between the ages. Which goes against Kawasaki's illness, right? Because Kawasaki's is mostly in the younger kids and not so much in the older kids. And they see a less amount in our younger kids who are the higher risk with the primary COVID infection and kind of equal across the rest of the ages. By race, these actually correlate a lot with our acute COVID infections that we're seeing. And so it goes along the same line. And then the case also met the 5 criteria of that the CDC had established. Of these kids, 80% had some effect on the heart. Which is a daunting number, actually. Of these kids, 50% were elevated troponins, and 73% had elevated BNP. 91% had echoes performed. Sort of interesting where the other 9% went with the echo, or why no echo was done on 9%. But of these kids, 5% had ejection fractions less than 30%, which is not a great number. 8% had a Z-score that was consistent with potential aneurysm development, and 48% required vasopressor support. 4% required ECMO. The other organs that were impacted due to MCEP in the US, GI was predominant, with next being hematologic, so looking for DVTs, elevated D-dimers, and then respiratory, which was interesting because in the initial COVID presentation in kids, most of them didn't have the severe respiratory symptoms. But of this one, particularly in the older kids, age 13 to 20, which is the dark blue, a lot of them had respiratory insufficiency or had infiltrates or required ventilation. This is in contrast to the under 5-year-olds who actually did pretty well from a respiratory standpoint, but had a lot more GI symptoms. The lab studies that they evaluated, all the kids had elevation of or abnormalities in their labs. Majority of them had lymphocytopenia. If they were, again, the older kids had the more severe presentation, except for in this group, the 5 to 12-year-olds had elevated BNP. But again, all of these markers were elevated, which is kind of interesting. You got to remember, in the peds world, most of these numbers are completely normal. So for us, we're like, I've never ordered a D-dimer on so many little kids, which comes with its own sort of problems there too. So for treatment-wise, 77% got IVIG. A little disappointing as to why 100% didn't, but it's possible they didn't meet the full Kawasaki's, because again, we were treating this when it first came out as a Kawasaki type presentation. 21% required a second dose, probably because their fever did not break in the 48 hours. We did use steroids, which is not something we use in Kawasaki's, but is being used in COVID, and since this was linked to COVID. And then they were recommending anticoagulation and some of the DMADs, which like Anacarna, Kinro, which is used for rheumatoid and stuff. And those were a recommendation. 80% of these kids went to the ICU, and 4% required ECMO. Significant number of patients. It ends up being, I think, eight kids required ECMO in this 2-month period or 3-month period. 20% required mechanical ventilation. 2% died. At the time of the publication on May 20th, 28% were still hospitalized. There's not been a follow-up data on this yet. I anticipate it'll probably come fairly soon. But most kids stayed 70 days. So, we went from COVID doesn't hurt kids at all to, this is kind of ugly. In looking at comparison, because we do associate it with Kawasaki's, there is definitely some overlap, but it's not absolute. Only 20% had the full Kawasaki's disease. 19% had what we called incomplete Kawasaki's disease, but 61% were in the other category. So these kids had between 0 to 1 Kawasaki disease-like features. So they either had like a rash, or they had swollen joints, or they had, you know, a sore throat, but they didn't have anything else. And then, or some of them had 2 to 3 features, but they didn't have any labs. So their labs were completely normal, but they had the inflammatory features or the symptoms of Kawasaki's. All the kids had a fever. And this is actually important because purely anecdotally, I think we're seeing a subset of kids. I've heard it from other colleagues at different hospitals where we're seeing no fever, but they have, their temps are 99 to 100, but they've got Kawasaki type rashes and stuff. I have a dog snoring right behind me, so I'm sorry if it sounds like I'm growling. Sorry about that. They did have, the ones that were complete had all of the typical Kawasaki type symptoms. The ones who were incomplete, interestingly, had a higher rate of aneurysm, which to me, that's actually really concerning. And then the other features were there. So it's not exactly Kawasaki's. It's not exactly not Kawasaki's. There's definitely an overlap and there's definitely a correlation, but I would hesitate personally to call these interchangeable. I think that it has defined itself as its own syndrome. So in summary, same thing we just talked about. CDC is who, what the CDC presented is what stands as who has it. Their signs and symptoms, it's Kawasaki's disease-like. However, these kids are hemodynamically unstable. They do have some inflammatory features. Most of them do have GI symptoms. They can develop abnormal clotting and bruising, and some do have respiratory symptoms. What tests do you order? Pretty much the kitchen sink. These kids get all the inflammatory markers. You do want to do a CBC, you do want to look at electrolytes. Cardiac enzymes, BNP and troponin may be elevated. Urine, we will see the red cells present. Chest X-ray, you might see cardiomegaly and you might see signs of heart failure. You should get an EKG and just make sure there's no arrhythmia. There's not been any interval changes that have been linked to MCEP yet, so we don't see like a prolonged QT or anything like that, but definitely should still do the screening just until we sort this out completely. If they are hemodynamically unstable, try to get that stat echo to make sure you're not dealing with any kind of abnormalities. And then do the other viral studies. There's still about a 20% crossover with COVID and other influenza or other type viruses. So make sure you look for the other viruses as well. Do the PCR, and then antibodies, if we do them initially, you may be in the window where they're negative for antibodies, but they're still negative for their PCR, and they haven't developed the antibodies to the testing yet. So, but go ahead and do them, and then you can test them later. Most hospitals have come out with a protocol. Has not come up to one. Then this is actually a great one to use. Children's Hospital of Philadelphia, and it's actually on the ACEP website in their COVID link. But they basically, they look at a 3-day history of fever. And then you have to have greater than 2 clinical or historical features. And they recommend initial lab testing. They don't recommend the cardiac exams right off the bat. CBC, comp panel, CRP, and a SED rate. And then if all that looks good, they go home. If there's concerning, but you're definitely not up to the level of MCEP, they do recommend admitting to observation. And the reason for that is that these kids do change. Some of the kids in the study had very little symptoms, and then 24 hours later went into fulminant shock. So you want to actually observe. As we get busier with other respiratory things, that might be harder to sell to the pediatric floor, but right now it's not too difficult, at least not where we are. If they do have the elevated labs, primarily the CRP and the SED rate are elevated, and you've got some thrombocytopenia or your sodium is low, then they recommend the further evaluation with the cardiac. And at this point, they recommend the studies as well as a cardiac consult and an echo. If they come into you with MIS-C, but they're hemodynamically unstable, then they do get everything. They get myocardial dysfunction testing, echoes, vasopressors. You're going to treat them like a septic pathway, correct? You're going to do all the studies, but you're going to do the fluid resuscitation and the vasopressor. Intubate early if you feel like you don't have a good handle on it. If the labs and all that are negative, they can go home. IV fluid, the treatment they recommend is you do the initial 20 per kilo rapid. Keep repeating that as you would for sepsis or shock. Start at the IVIG if you have a good idea that this is what this is. You probably should consult your infectious disease, but it's okay to start it earlier than later. Steroids, the studies, the different people were using any range from 2 to 30. I have no idea how they got up to 30 mg per kg per day. That seems like a lot, but that was what was being used. They do recommend the DMARDs. Antibiotics are to be considered until you have an absolute idea of what is going on, particularly if you have an unvaccinated patient, pediatric patient, or if you have a mixed picture of both Kawasaki's or the MIS-C, or you don't have a good handle that they've definitely been exposed to COVID. Starting low dose aspirin, you could probably wait to start that on admission. If you do, I doubt we're sending these patients home yet. I think as if this progresses and gets more and we find this middle ground more, we may end up starting these kids on steroids and sending them home. But either way, they all need cardiology as a close follow-up. What's the long-term effects? We don't know. We don't know yet, as hasn't been around long enough, but there is concern for long-term cardiac involvement. I think anecdotally, the concerns are that we are not detecting all of these because these kids are, we get the ones that are super severe, but we're not getting the ones that are not as severe because it may be a fleeting type thing because they're not consistently febrile for 5 days. They don't have all these symptoms for 5 days. So the concern is that we're going to have a bunch of kids later down the line that do have cardiac effects. Same thing that you've got going on in the adult world. I do know in Kawasaki's disease, after the 6 weeks, if you've not developed an aneurysm, you're not going to once you've cleared the convalescent phase. We don't know if that's true with MIS-C or not. Moving on, and then I guess I'll do questions at the end, but the other concerns that we've got going right now with COVID and kids is there's a lot of them you're hearing through your, I don't know, if you have children, you're hearing through your kids' schools or through your primary care physicians and stuff. But we're really worried about missing other illnesses in kids. Most of pediatrics has been relegated to telemedicine. Kids are not getting face-to-face with their docs, so we're relying a lot on parents giving good histories, which so far is okay. There isn't any hard data on how much we're missing. We are very delayed in vaccines, particularly in the New York City area and also in the Detroit area. My understanding is they're doing their best to catch up. Definite safety concerns. Child abuse hotlines report that about 30% of their calls come from schools. So when these kids are out of school, they're just not in front of people that can help them. We also have had problems with our special needs kids because a lot of those schools closed down as well, and parents are just not accustomed to doing everything with these kids. School meals, nutrition, I think the public schools are doing the best they can do. Hopefully that continues as they continue online in the fall. Lack of sports interaction, so there's some social development. Mental health, some kids are thriving at home, being home with their family, not having to worry about getting up in the morning, not having to worry about the strict routine, not having to worry about being in front of their friends every day or their school kids. Some are having separation anxiety, some are not doing well with their lack of routine, so just keep all that in mind. But the biggest problem is we don't have our kids in school and academics are definitely falling. So this has prompted a lot of discussion right now on whether kids can actually transmit COVID or not. The CDC just released a return to school guide. And so I dug into it because I know politically there were issues and all that, and I'm not trying to get into the political side of this, but it was such a abrupt your kid must go back to school regardless of this pandemic we're in the middle of, that it caused me a little bit of concern. So I dug into their 6 references that they used to talk about whether it was safe to go to school and whether the kids actually transmitted. And I wanted to go through them with you so that you're educated on it, so that it's not, you can eliminate the politics and all that and just go with the facts. The first one they did was out of New South Wales. They looked at 15 schools and they had 18 cases in those 15 schools. 9 students and 9 staff. Of those 18 cases, they stated only resulted in 2 secondary cases in students. But the thing is, the schools closed 2 weeks after the study was started, and they did not say when those cases were. So if those 18 cases were the day before schools closed, they may not have had all the interaction. Also, the follow-up to that is that they only tested 1/3 of the contacts. So of those 15 schools, they identified who was considered close contacts, and then they only tested 1/3 of those contacts. So I'm not sure they got everybody. So I don't totally trust that data. Then scientists lugged this and reviewed 700 papers and letters and 47 full texts, all written before May 11th, looking at whether kids transmit COVID or not, and came up with 3 conclusions. First, that they may have a lower viral load than adults, partly because they have fewer symptoms. I would think they have fewer symptoms because they have a lower viral load. I did quote these directly from the studies, but that should decrease the transmission risk. Okay, household transmission studies showed children were rarely the index case, and so therefore they weren't bringing it home, and that they seldom caused outbreaks. But then they say it's highly likely that children can transmit the virus, and even asymptomatic children can have viral loads. So really not super yay, go back to school. Then this was actually my favorite study I think I read in preparing this whole lecture. Danish described a tourist who stayed at a Swiss chalet who infected 75% of the other guests. Of the guests, one was a child who then for some reason went to 3 schools. I don't know if this kid was like a child prodigy and going and tap dancing. I have no idea why this child went and visited 3 schools in the week after being exposed. Apparently this kid also had a runny nose and a cold symptoms and was diagnosed with coronavirus and influenza A. So this poor kid who had been at a Swiss chalet as a tourist, then went to 3 schools, also had viruses, and apparently was also positive for COVID. They claim that the child spread the other 2 viruses, but only 1 case of COVID was found in all 3 schools. But what they didn't say was whether the coronavirus and influenza A, which were both probably running rampant like it was here, was already in the schools. So that study was just kind of a hot mess. The next one was the World Health Organization China Joint Mission, and they said that from available data and in the absence of testing, it's not possible to determine the extent of infection among children, what role they play, and whether children are less susceptible. So I thought that was interesting that they used that as a reason that kids are not susceptible. So I quoted that directly. So yeah. The 5th study was actually probably the only one that made a lot of sense. And it was the Institute of Public Health in the Netherlands. And now the Netherlands currently, as of yesterday, has 52,000 cases, 6,000 deaths, and 17 million people. So a little bigger than our state of Michigan, right? Because we have about 10 million people, I understand. But the numbers are actually fairly close to our numbers. They do report that after they reopened in May, there was no sudden increase in the reproduction number of COVID cases. So that, without any link in between, is actually sort of interesting. And then finally, they looked at the spread of COVID in Iceland, and they determined that kids under 10 were less likely to be positive than older kids. Okay, we know that. In targeted testing, kids had less than 10 at a 0% rate, and 10 to 18 had a 0.9% rate. So we knew that from the studies back in China. We know that kids just don't get COVID. Before the CDC released this return to school guide, there was a South Korean study that was actually released in the CDC's Emerging Infectious Disease Journal. And it looked at all the ages, and they did contact tracing, all ages of all the cases in South Korea between January 20th to March 27th. they had almost 60,000 contacts from about 6,000 index cases. So of the cases that had contacts that were sick, the contacts that they looked at that were sick, 11.8% were positive. So they were contagious. They had gotten their COVID infection from someone in their own household. And of the cases that got infected, or that they were the contacts, only 1.9% were positive. It was from the outside. So if we're looking at a school, how that's related to the kids is that a child gets a COVID at home or at school and they bring it home, they would then be the household contact, right? Versus the child at school transmitting that to another kid in their class. So that would be the non-household contact. But the highest rate of transmission was 18.6%. And this was for kids aged 10 to 19 years. So that's basically our fifth graders through our college students, so to freshmen in college, our fifth graders through graduating seniors. They were 20% of the transmission came from them to their household contacts. So that would mean our kids would go to school and they would come back and bring it to us and to their grandparents and stuff like that. The lowest, however, was in the little kids. So in our preschool through fourth grade was the lowest rate of transmission. So they weren't coming home and bringing it to the grandparents. The speculation on this was that it actually was stated that they're short. And when they talk, their respiratory secretions fall at our knees and our hips. I can't argue with that. And also then I tend to think, well, 10 to 19 teenagers, not the best hygienes, right? I got two of them, I know. And so they are more likely to leave their dirty tissues and all that stuff around. So I don't know, take that with a grain of salt. But there was one article in this one, it's the last study I'm going to quote, and that they quoted as to why we should really think twice about whether we're reopening our schools or not. And this was a contact tracing from 2 months of data in Wuhan, Shanghai. Now they considered, they did, it was an abstract analysis that they did looking at the transmissibility of kids. And they took into account that kids were less likely to be infected. And they found that social distancing alone, as a side part, alone was sufficient enough to control COVID. So by keeping people apart. But what they did do after all this analysis, and I thought about putting it all in, but it actually is just a lot of data, but that was hard to show. But their conclusion was, although proactive school closures cannot interrupt transmission on their own, they can reduce the peak incident by 40 to 60%. So that is from an area that tested everybody and looked at everybody and has everybody tracked on their phone. So they were able to determine that with these kids stayed home, 40 to 60% reduction in the peak incidence. So if we're hurting for ICU beds and we're hurting for places in our hospital, it does make sense to close down these schools. The concerning part is if it's interrupting, that means that it's also causing and it's contributing to the transmission. Really makes you stop and think whether we should be sending our kids back to school. Now, the one part of this is that China school-age kids only make up 10% of the population, and in the US, we're up to 20. So at least at very minimum, again, don't want to get political, but at very minimum, we need to consider, and we need to, as physicians, we need to stand up and say, I understand that we need the academics and we need the social and we need all that. But if our area is having an outbreak of COVID, we need our kids at home because keeping them at home can stop that transmission. So in summary, primary COVID-19, most often mild or asymptomatic. We really don't have to worry too much about COVID-19 as a primary infection in kids. If a kid comes in with fever and cough and there's nothing else going on, you should, or even if there is something going on, you should probably get a COVID test and probably recommend that they isolate at least till they are fever or cough free. And this goes with the back to school plans and stuff like that too. If they have any comorbidity, particularly cardiac, have a higher rate of suspicion, maybe consider observing these kids, especially while they have the fever and cough. Don't tolerate as much hypoxia. You know, in RSV, we tolerate hypoxia down to 88% in kids. I'd have a hard time in an older kid who has a congenital heart issue tolerating that unless that was their baseline oxygen. But that was otherwise healthy, but just had some comorbidities that I would have a hard time tolerating that in a kid. Suspect MIS-D in any child who presents with Kawasaki-like illness. Even if they haven't had the fever for a full 5 days, go ahead and do the test. At any, you know, the worst case you'll get, or best case you'll get, is all their labs are normal. You have a baseline to compare if they come back in 2 days with worsening symptoms. And kids can transmit. We don't know how much, but we do know they can transmit. And we still need to be diligent. Kids still need to wear masks. And we need to be diligent about keeping these kids apart. The good news, I've got to, I always try to find the rainbow or the happiness in this, is that there's great studies that are popping out now that say, hey, we've had less fractures over this course of the kids being isolated because they're all tucked at home, sitting on the couch watching TV, but they're not breaking bones. So I'm wondering if longer term, you know, we may have a decrease in, you know, long-term bony arthritic illnesses and stuff like that, because we have this population of kids that went through this nice period of time where they didn't break anything. In Ireland, they're saying that preterm birth numbers have dropped. They're attributing that to lack of stress, which is odd to not be as stressed during a pandemic, but maybe they're taking care of their pregnant people. CDC data, only 7% of the total cases and less than 0.1% of the deaths. So that's good. Our kids are not dying of this, which is good. Social distancing in mass in school may reduce the spread of influenza and RSV. Yay, that would be so good. And we can see the Himalayas again. So that is the end of mine. I thank you particularly to my colleagues who are out there on the front lines taking care of all these adults, particularly you guys down in Detroit. I thank you so much for all the work you're doing. And if you have any questions, I can help on the ped side. I'm not the best on the adult side anymore, but if there's anything I can do on the ped side to help, please reach out to me. I'm happy to do what I can do. Thanks.
Thank you, Dr. Coffey. We did have a couple questions out there, and I think you answered a lot of them with a lot of your data that you had in there. What's kind of your thought process on when you would start the workup? Are you waiting at least 24 hours, or what's kind of your cutoff for saying, like, someone's got at least 1 or 2 of the factors plus how long of a fever? Because normally Kawasaki, we always talk 5 days, but then we saw the Philadelphia one, I think said 3 days or greater, I think. Are you
the CHAPS one said 3 days. Detroit Receiving, the one we were following that was dated back in June, wanted 1 day. I personally worked them up with a fever. We don't have enough data. There's enough data that shows it's not exactly the same as Kawasaki. A lot of the reason for Kawasaki is the reason, and I probably could have said this, as long as you get the testing done and the IVIG started before the 2 weeks, you are in the window to reduce 95% of the cardiac complications. So if you test, and we have so many illnesses that cause fever in kids, right? The majority of them don't go longer than 5 days. Flu is an exception. Some of our flus this year went 7 to 10 days. Adenovirus is another one that goes 7 to 10 days. Metapneumovirus can go, 6, 7, 8 days. But for the most part, most of the common colds, most of the common illnesses, fever is less than 5 days. So the reason for the 5-day cutoff for Kawasaki's is that takes you into a whole nother level of illness possibilities, right? MIS-D is not following that same pathway. There are kids who are getting super sick with just 2 days of a fever, and they're going into shock-like symptoms and stuff, and they've only had the fever for 2 days. So we don't have, that's where it digresses from the Kawasaki algorithm. Personally, having read all of this, I have a hypersensitivity to this. Purely anecdotal, in the last 3 shifts I've worked, I've had 3 kids that have had temps of 999 and have had all 5 symptoms of Kawasaki's. So they all got worked up and they all had elevated CRPs and normal sed rates. I admitted one because her feet were so swollen she couldn't walk. Her rash was so diffuse, her lips were all chapped. I mean, she had wicked cervical lymph nodes. But we couldn't get her temperature over 99. It was insane. I mean, I kept trying. I kept, here, aren't you hot yet? No. And so she got sent home. After a day, everything resolved and she was fine, but she did get started on high-dose steroids. So her PCR was negative. Her initial antibody was negative. I'll be curious in a month if her antibodies turn positive. She did have a significant exposure. Another one was very mild, all labs were normal, sent home. So I don't have the answer for that. I would err on the side of caution with this because you would want to detect it early. So.
I think we got one last question before we move on here. I saw in the comments, one of the other questions they talked about kind of what are your, obviously this are your thoughts, like what are your thoughts on long-term comorbidities? I think a couple of people mentioned, like obviously, you know, Kawasaki, like you said, a lot of people, if you get it treated and they're doing those things, we're not seeing aneurysms, we're not seeing long-term deficits. Do you think that we're going to see some people with some like long-term CHF and things like that we just don't have a lot of data on yet, obviously, but what do you think?
I don't know. I mean, I think it's going to follow the lines of the adults, right? You know, we're starting to see these what are they calling them, the long-termers, or the people who have chronic illness from their initial infection. I think that MCEP, if you look at it, it's like this minor portion that follows the same pathway as the general COVID infections. So personally, I'm hoping not. I'm hoping that once they get over the acute illness, they don't have, so I think somebody commented about the ACE inhibitors. So one of the reasons, and I didn't include this because there's not great data yet, but one of the thoughts of why kids aren't getting COVID is that they just don't have the ACE2 inhibitor receptors, right? They just don't have as many of the receptors. So coronavirus just doesn't latch on as much in kids as they do in adults. So does that mean that all of the cytokine effects aren't as great? We don't know. We have no idea. I think that if the adult population does really well long-term with it, that kids will do well long-term with it. So, but no, we just don't have the data, sorry.
All right, well, thank you, Dr. Coffey. I think they're gonna shoot off a quick poll and then I think we're gonna be introducing our next speaker. Thanks a lot.
Interesting poll results. You know, kind of goes along with what I think many of us have seen.
Yep, that's exactly right. You guys in Detroit, I mean, did you see a lot? You know, Lansing was sort of, we shut down so early for us that we didn't have a ton. We still haven't had a ton. Have you guys seen a lot of these kids in Detroit?
We were not seeing a whole lot of kids at all. Like the whole, like entire visits of pediatric visits were way down. Kind of starting to come back a little bit, but overall illness, overall injuries, all was way down.
Was way down. Is your volume still really low in kids? We're still at about half. We just haven't recovered yet.
Brad may be able to answer a little bit better at Beaumont, maybe.
Yeah, peds volumes are very, very low. We've seen a little bit of an uptick, but nothing close. Our overall volumes are rather low and not appearing to come back.
Yeah, same with ours.
Yeah, at Henry Ford, we don't see a ton of kids to begin with, but there's there really haven't been many kids who've come in.
Yeah.
Today. But All right, so we'll kind of keep going here. We're gonna just want to remind everybody, if you called in and your name's not on there, make sure that you're sending an email to let us know that what your phone number was that you were on, so you can get credit for CME. And then if you do need AOA credit, make sure you're emailing with your name and number so that you can get AOA credit also. And then we have 2 more events coming up on August 25th and then again on September 30th. I think it was on the slide earlier for upcoming summer series events. And then we are going to hear our last shout out from Senator Gary Peters.
Hello, I'm U.S. Senator Gary Peters, and I'd like to take a moment to say thank you. You're on the front lines each and every day helping us get through this pandemic. You have stepped up selflessly, and you are a big reason why I know we will emerge stronger than before. That's why I'll keep working to provide essential workers a well-earned raise, personal protective equipment, and other resources to ensure you can continue to do your job safely and effectively. Thank you again for all that you do.
All right, with that, we are up to our final speaker of the day. I want to thank everyone again for their attention and for being here with us today. You know, today had a very COVID flavor. We're going to mix it up for the next 2 sessions. So please come back and join us for some more free CME from some of our favorite speakers. So I'd like to next welcome Dr. Greg Gaffney-Pappas, President-elect of the Michigan College of Emergency Physicians as of yesterday. Dr. Gaffney-Pappas is a serial entrepreneur as well as an emergency physician, balancing a variety of intriguing side gigs with clinical work, advocacy, and his family balanced. Welcome, Dr. Gaffney-Pappas.
All right, thanks for having me, Therese, and Abby and Jeff, and thanks for putting this together. Really excited to be here. Can you hear me okay? All right, I'm gonna share my screen here, and hopefully this all works flawlessly. Okay, and give me a thumbs up if you guys can see my screen and everything's working okay. Okay, awesome. All right, so this is a topic that is near and dear to my heart. I really think that doing things on the side, whatever it might be, is really important just to kind of maintain some really happiness in your life. At least for me, this has always been an important part, is doing lots of different things. In some respects, some of the side gigs I do are my hobbies. And then you can also have other hobbies on top of that. I tend to dabble in a lot of things, and probably too many things. And it'd probably be better to pick one thing, but I like to learn about different types of side gigs that might interest me and that I might be excited about, that might bring in some money, might not so much, but something that adds to my clinical career and to my personal life as well. So what I'm going to do in this is go through a bunch of different side gigs and some information that might be able to help you. I am not an expert in every one of these topics. I certainly would love to be one day, maybe an expert in many of these. I have had a lot of experience in a number of these topics, and so you'll get to see some of that as I discuss some of it. My hope would be is that potentially we could create, and we've talked about this, some sort of conference around many of these ideas, bring in experts on each one of these topics to discuss this different information that would be able to benefit emergency physicians throughout the state, and allow us to potentially, if you're looking into doing some sort of side gigs or other types of added benefits to your career, that we could have that in the future. But this is really an overview of it all. So I'll go into it. I have no disclosures, with the caveat that I'm going to talk about my own experiences as well as other companies and provide examples. I don't endorse or promote any specific brands or companies listed in this presentation. I do not receive any money or commissions from any of these companies, including many of my own at this point. So I just want to put that out there. All right, let me just real quick All right. So what is a physician side gig? Really, a physician side gig is anything that supplements your regular day job. So anything, it could be something, and initially we called this non-clinical side gigs. This could be something clinical outside of the emergency department. It could be clinical doing something like locums, and we'll talk about that. But it's something that supplements your regular day job. It may not make money right away. Maybe it does make money right away. It's not necessarily a hobby and something that you do and then you don't make anything on it. The idea, I think, eventually is to make some sort of money on it, or have it be, and added to your specific career in one way or another. But it is anything that supplements your regular day job. And what's the big deal about it? When did physician side gigs gain so much steam? There are Facebook groups out there. There are multiple blogs that people follow. And I think that part of this relates to three things. Number one, burnout. I won't go into details because this is not a burnout lecture. We already talked about resilience earlier, which was fantastic by Dr. Hope. But I think, there's a lot of burnout in our specialty, and people are looking for other things, whether to decrease their clinical time or just add it on top of it that they can do that makes them feel fulfilled. The other is extra money. Certainly, many of us are always looking to make a little bit of extra money, or a lot, depending. Side gigs, certainly, some of them will make more money, some of them less, but they have the potential to make more money. And then the last is balance. So something that balances out both our career and our life, something extra to do. Sometimes when you're just stuck in the emergency department working clinically all the time, and not just, with burnout, but you can get kind of, not necessarily bored of work, but it just becomes somewhat monotonous at times. I think we've probably all experienced that before. There are certain exciting things, and there's other things where you're seeing, the 100th abdominal pain of the week, and it's just a little bit monotonous. So I think balance is really important. There are a lot of questions to ask yourself before going and doing a physician side gig, or some sort of side gig. Side hustle is another term, by the way. But here are some of the questions that I thought of. So am I doing it for the money? If it's just for the money, it might not be worth it. You have to have other aspects to it that are worth it for you. But certainly, money's one aspect. What's my time worth? Certainly, we've all thought about this before. I've thought, okay, I do mow my own lawn. So that's one thing I've decided to do. But I don't do certain other housework. And I say to myself, well, how many shifts do I have to work to cover this specific housework? So what is your time worth? And how much money can I make doing this? So that's another thing to think about. If it's $10 but you love it, then maybe it's worth it. If it's $1,000 but you really hate it, maybe it's not worth it. So there's a lot of things to think about. And then could I simply work more clinically? It's an option. Sometimes, at your shop, you're able to just increase your shifts by 1 or 2 a month, and that brings enough money in that, hey, you've got the money that you want. You don't have to do a physician side gig if that's not your thing. So there's some other questions. Do I want to add balance to my clinical career? We kind of talked about that. Is it something I'm interested in or passionate about? If you have a passion, let's say you have a passion for fixing up cars, and then you fix up cars and want to sell them. I mean, there you've got a side gig right there. There's tons of different passions you can have, and sometimes if you think about some of your hobbies that you do already, some of those could be turned into a side gig if you really wanted to. So think about what you're passionate about. Sometimes that takes a little bit of exploration and doing some things first to figure that out, but it's something to think about. And then, will it get me closer to my ideal life? Sometimes the answer is yes, and sometimes adding a side gig on top of your personal and professional life is not really going to be an option in terms of the time it takes. So just think about what your ideal life might be. And can I gain financial independence sooner? This is a big term lately, the term FIRE, where you get financial independence at an early age. You can retire, you can do what you want. There are certainly some things that might get you to that financial independence, and we'll talk about a few of those. But again, what are you going to put into it, and what do you want to put into it to get to that point? And there are some other things you might be able to do first without a side gig. So again, things to think about before jumping in and doing a side gig. And the last thing is, does it make me happy? I think that's the most important question. If it does not make you happy, it is not worth it, even for the extra money. It's gonna make you even more burned out. It's gonna cause probably more strife in your personal life, and it's just not worth it. So always think about that. Does it make me happy? Is this a get-rich-quick scheme? By all means, no. So that I say sorry. It takes a lot of work and a lot of time to make money from some of these side gigs, but it can pay off in the end. So it's not a get-rich-quick scheme for sure. So don't think about it that way. And is it going to get rid of all of your problems? Again, absolutely not. It may create more problems for you. But I think, it depends on what you're doing and what makes you happy and what kind of the timeline is for each project that might be something to look into. So what does it take? It takes desire. You have to want to do this. It takes motivation. It takes persistence. And when I say persistence, I mean really a lot of persistence. It takes failure. I've started about I don't know, 5 or 6 different projects I can think of right off the bat, and most of them have failed in some way. Maybe they're not a full failure. In fact, there's been some success related to them, but it's not like I've made millions of dollars related to some venture that I've started. And if your goal is money, that's one thing. There's success based on just the fact that you learned a lot from it, or that you're doing something that you really enjoy. Maybe you're not making as much money from it, but you love doing it and it's worthwhile. So again, things to think about. And then it takes time and it takes money. In emergency medicine, one of the nice things is that we work clinical shifts that are sometimes evenings, sometimes nights, sometimes days. And so we have this different time potentially to work on some of these projects that we want to do. And that's great. But it still takes that amount of time and extra time that you want to put towards it. And then money, we have good careers, we make good money, but we have to put money in order to start to have some of these side gigs work. Some of them require more money than others, but it does take money to start some of these. So this is kind of the beginning basics of why to do side gig, what it takes. And what I'm going to do, and again, why do it? The main thing is because it makes you happy. And I think that's really important. If you think about something or you're doing something and you say, listen, I'm just not happy, this is not working for me, and that's happened to me before, I think you have to kind of reevaluate and say, maybe I shouldn't be doing this. Okay, so we're going to go through a bunch of categories of physician side gigs, and then a couple of things at the end, and then I'll take questions. Please ask questions as we go along, and if there are any at the end, I'm happy to answer them. So I'm going to start out with the medical clinical side gigs. So these are using your license to actually do clinical work that is potentially either emergency medicine or outside of emergency medicine. So we'll start with locum tenens. And again, the one thing I would say is that a lot of you might have done all of these before and might be more expert than I am. So the idea is really to get some of this out there and show you the things that are available and possible. So locum tenens, many of you know about this. You can sometimes do it in your own area, but a lot of times you have to travel. There are 3 specific times that people say they're best for locum tenens. And there may be more than that, but after residency is one of them because you can travel a bit. Maybe you don't have a family quite yet, and you can make some good money doing it. Mid-career is another time a lot of people look into locums. And then the last is late career. You're not quite ready to retire, but you don't want just the regular job that you've had for years. Maybe you want to travel a little bit, and that allows you the opportunity to do that. So the pros are really high income in some areas. A lot of times you're going to make the same income that you would in your own area, but it is an option that there are certain places sometimes where you can have a higher income. And you get to travel a little bit and see new systems, see new areas. The cons really are, I think it's difficult with a young family. I can't imagine doing locums personally right now with my family. But the other thing is that you have to learn a new system. I think sometimes that's easier. I have a friend who's in anesthesia, and I feel like for him to go and do locums somewhere, it's very much the same operating room as other places other than different people. Whereas in the emergency department, we rely a lot on the resources available to us, the specialists in the area. And I think that can be a little bit difficult sometimes. So that's locums. That's certainly an option and a way as a clinical side gig. Telemedicine is another one that has gained steam recently. Again, the pros, you can work from home and you can earn pretty good money doing it. The pay is based on hours, so that's one of the cons is that, and consult. So you kind of have to be available for the consult in order to be paid to do, for the telemedicine visit. And you don't have a physical exam. So for those of you who really feel strongly that you have to have a physical exam, there are certain things you can do through telemedicine to get some physical exam stuff and some new technology out there. For the most part, it's very hard to listen to the lungs or do stuff like that. So something to think about. Urgent care shifts. So this is a great way for some of us to get a little bit of extra money. I worked in urgent care as part of our system. It wasn't a side gig, it was actually part of my shifts, and I helped direct it. But we also had some people coming in and just wanting to do extra shifts from emergency medicine or outside of that was very beneficial for them because they get a flexible schedule. Compared to your acuity in the emergency department, it's very low acuity, and anything that gets higher, even to moderate acuity, you can just send right over to the emergency department and have your colleagues deal with it. Sometimes that can be nice. The cons is that you are working extra shifts. It is clinical, and generally you are paid a little bit less hourly to work in urgent care, but it's certainly an option, and we'll talk about it later. But better yet, start your own urgent care if you really want, and there's some money in that. Concierge or on-demand physician has become a little bit bigger recently. This is the idea of actually going to someone's home potentially and treating them there. Sometimes people have more of a concierge area where someone can come to them, but it's in a very it's just in an office building. But a lot of these can be portable emergency physicians. So this is a picture of Mitch Lee. He's an emergency physician who has a company called Thrive Direct Care, and he goes out and treats people with urgent, kind of urgent complaints versus sometimes more emergent, depending, and he does that at home. And there's another website I saw called Physician House Calls. So there's lots of people who are kind of going out and trying to create their own practice doing this. Heal at the top, you can see there is a company that is employs home physicians where you can go to someone's house as well. That's an option without starting your own company. The pros, generally, there's no insurance to worry about. These people do this without, for direct payment. Sometimes you can get insurance as well, but a lot of it's direct payment. It is part of entrepreneurship, so you could have your own company. The cons are really, it is clinical work if you want to do something outside of clinical work. It is house calls, so you have to drive to someone's house generally, and the startup time and capital is probably a little bit more, but can be worth it once you get your patient base. So odds and ends clinical work, we'll move on. There's plenty of different clinical work you can do through doing military physicals, medical review officer. You could be an addiction specialist and do a fellowship in that. You could start a ketamine clinic. There are 2 ketamine clinics, one in Royal Oak and one in Ann Arbor now, that treat people with depression and with chronic pain. It's becoming a bigger thing around the country. We're primed to do that because we're emergency physicians and we use ketamine. So that's an option. A medical director of a hospice or nursing home or infusion center, these are all options if in your area. And then clinical lab director is another thing that you could do. You guys still see me? My internet connection said it's unstable. Okay, good. All right, cool. So we're going to move on to medical non-clinical using your degree. So this is using your degree to do something that's non-clinical. There's plenty of these as well. So we're going to go through a bunch of those. So many of you are already involved in either emergency department or hospital administration. So I've done this for a number of years, and I will continue to do it. I really enjoy a lot of the administrative work. What it does for me is it decreases my clinical time. It really doesn't increase my income. Some places your income is increased depending on what you're doing and what company you work for. But I think it can also be really just a satisfying part of your career where you get to do a lot of quality improvement. You get to manage many of your physicians. And so I think it can be a really satisfying part of your career. I think that the cons for me really are that, number one is you usually work more when you do administrative work than you would otherwise if you were just doing clinical work. For me, it doesn't seem like more because I enjoy it, but it is more. The income may not increase. So again, you're getting a buy down usually in your clinical shifts, although it depends on what kind. If you're doing hospital administration, certainly there's a different pay structure there. And then, finally, it's really the bureaucracy. There was that one poll that we did where we said, what are the issues that you guys have? And one of them was administration. And I thought that was really telling for many of our institutions. There has become a bureaucracy both within a lot of our emergency department companies, as well as the hospitals, that you have to go through different leadership to get things done, and sometimes that can be difficult. If you know how to deal with it, it's great, but it can be difficult as well. So this is one path to having kind of a side gig that's non-clinical, but yet within the emergency department. Okay, now we're getting into some other stuff. So expert witness. Again, many of you have probably done this before. I've done some expert witness work. It's actually pretty satisfying and interesting. I think that the pros are, it is certainly really good money. Many people are charging $400 to $500 per hour, which is quite a bit. You can do some interesting case review with expert witness work. I think that the cons really are thinking about whether you're going to do plaintiff versus defendant work and pigeonholing yourself in one or the other. It can be hard to do plaintiff work when you're going against people, your own emergency physicians within the country, especially within the state. I've typically done more defendant work just because I think at this point in my career that makes sense. I think that another con is that you have to have thick skin on the stand. You're going to get berated by some of these other attorneys, and you have to be able to handle that on the stand. And it can be difficult to get clients. I found that referrals are the best way. SEEK, I put up here, is an organization that does help have courses on expert witnessing, as well as directories that can get you expert witness work. The directories can be good, but I would say be careful with that as well, because some of the people that might tap you for expert witness work might not be as ethical, or might not, the work might not come out like you want it to. So just be careful with that, but there is some great resources within SEEK that you can get as well. Okay, I put this in there because I just thought this was interesting. I don't think that there are a lot of people who are doing this, but there might be more than I think. This is an emergency physician. Her name's Ashley Elker. I have followed her on Twitter. She's very interesting, and she does TV and film consulting. I think from my standpoint, the pros would be that it's probably pretty exciting to do. It can certainly be extra income. I'm not sure exactly how much. You get to meet people in the film, TV and film industry, which might be really interesting, and also kind of jumpstart other things within that career. I think the cons are that it can be difficult to get started in this. You have to know someone probably to get to that point. Maybe do some writing for some films, and then you may have to travel a little bit to sets. Although I bet a lot of it can be done from home. But I just thought this was an interesting thought. I'm putting in some extras that that people might enjoy. I put in here medical surveys. I am a member of each and every one of these medical surveys. Here's what I would say about medical surveys. Medical surveys can be a way to get extra money. Not a whole lot. I think that from an emergency department standpoint, emergency physician, they're not looking for our, they should be looking for our opinions, but they're not looking for our opinions as much as they are from, say, rheumatologists and oncologists and people who might be more involved with pharmaceutical type stuff. But this is a very simple and free and easy way to get involved. They text you basically when a survey comes out. You have to do it pretty quick or they go away. But then you make money in a bank, and then over time they just pay you out. And so it's a way to do stuff. It does take work. It's not passive income, but it's pretty simple work for the most part. There are small surveys, and then there are larger ones as well. And then I'm just going to go through briefly medical consulting. There's tons of ways that you can do medical consulting, and way more than what I listed here. But you could help organizations or hospitals. You can do that on your own, or you could do it through like an organization like McKinsey. They do medical consulting work. You could do utilization and case review. I think we're actually pretty primed to do that. A lot of times radiologists are tapped for this, for large CT or MRI studies, but we order a lot of those and could potentially do these. This could be for insurance agencies, or it could be for other companies that consult with the insurance agencies. A lot of people are really against pre-authorization, but it is what it is. We can fight against it, but there is pre-authorization out there. So doing your work to help with that can be beneficial as well. You can be a health insurance claim reviewer. You can do disability insurance exams. There are a bunch of organizations that get you do the training for that and can help you with that. You could even do retail consulting. So there's a lot of people who do that, where a business wants to know about some medical product or something and needs a medical take on it, and you could do something like that. And in emergency medicine, I think this is a great way for us to get out there and do some consulting, because we know what could be safe and not safe, and different things like that. So that is our medical non-clinical. And now I'm going to move into some other categories just to talk about a bunch of other things that we can do as side gigs. So writing is, again, another thing that's near and dear to my heart. I've done a lot of writing. I used to do the newsletter for MCEP, and I really enjoyed it. And actually, honestly, that kind of jump-started me into doing a lot of other writing. So I'll get into some things that you can do from a writing standpoint. So let's go to the first thing. You could write a book. So some of you are like, I will never pick up a pen or type on my computer and write a book in my entire life. This is not for me. Others of you have been like, I've wanted to write a book all my life and I don't know how to get started. So there are plenty of ways you can do this. You can write a fiction book. You could write a nonfiction book. You could do an ebook. If you look here, you've got Atul Gawande's The Checklist Manifesto, obviously was hugely successful. Another one down below, and we'll talk about blogs later, but The White Coat Investor, he had a book. It's been actually very successful. And then you get into some other fiction type books. Michael Crichton, everyone knows. He was a physician initially, never actually practiced medicine, but ended up writing a bunch of books that were very successful. And then Abraham Verghese is a surgeon who wrote Cutting for Stone. If you haven't read that book, fantastic. But they both wrote fiction, and they're fantastic books. So to get into this, number one, I would look at different resources. Seek is another place that has resources. I would say they do have some fiction stuff, but mostly for nonfiction. Readsy is another great website that has a ton of information on how to write books, how to get started, how to find an editor, how to go through the publishing process. It's really exciting to do. I just personally finished my first science fiction novel, although I have to say I haven't got it published yet, and I still have to get it edited. But it's really a crazy process to go through and write 400 to 500 pages of fiction or any book. And it's worthwhile if you really like writing. So writing a book's a great option for you. I'll move past that and say start a blog. So I have a blog. I do not make any money from this blog right now. I just enjoy writing, and so I put out a blog. It's called Doc on a Mission at the top. It's just fun, and I put it out there because I just want to show you that I've done it. I've had the blog for 3 years. It's starting to get a little bit more traffic. Blogs can be difficult. On the left side, you'll see how to make money, personal finance, health and fitness, food, beauty and fashion, lifestyle, and personal development. These are the top blog categories that you could write a blog about. If you look at that, many of those could fit very well into something that we could write about. I put out The White Coat Investor because many of you might know The White Coat Investor. He's an emergency physician, Jim Daly, who basically has started this huge blog of tons of information about personal investing and many other things. And he has a whole network, and he's been wildly successful. You really do have to love writing. That's what the love is at the bottom. And monetizing your blog is a whole thing unto itself that takes some time and figuring out how to do. Something I have not fully figured out yet, but there's lots of ways to do that. But if you enjoy writing and you want to put something out there, it is worthwhile looking into doing a blog. Other writing type stuff you can do would be freelance writing. You could be a copy editor where you write, either you edit articles for people, or you actually put out content for different blogs or other websites. You could do a guest blog post. You can be a content writer for health and pharmaceutical companies. Medium is one where I've got on Medium. If you guys don't know about medium.com, it's a website where you can basically write articles, and you can actually make money from those articles by keeping it within this metered domain within Medium, only for people who pay for the Medium content. It's got a huge following, and tons of people can read your work on there. And so I've used that a lot, which has been great. Upwork or Fiverr is a great way to put yourself up. This is where you do freelancing work. You could again edit. You could do guest posts, and you put your information up there, and people will hire you. Or you could be a journalist if that's something you really love, and some people do that. So there's great ways to do freelance writing. All right. So I'm going to keep moving on here. You could write screenplays or movies. I'm going to go past this quickly, but this is Ivan Raimi. If those of you don't know him, he and his brothers made Evil Dead, the cult following of that movie. He works at Livingston Hospital in Howell, and has been there for years as an emergency physician. So just something to think about. You could do something in that regard. That's kind of like the TV film consultant, but you could actually write screenplays for people for different TV shows or movies. And then other writing gigs, you could do CME content, board review, prep questions, medical journal editor, and you can see that the CME Writers Marketplace is a place that you can go if you're interested in that as well. All right, I'm gonna go through a couple other categories, educate others. So some of this we've already talked about, but educating, we love to educate. Generally as physicians, I think we're educators. A lot of us have residents, a lot of us educate our family or friends. And so you could do that through here. You could have a blog. You could go and do an online course of some sort through Udemy or Teachable or one of the other sites. You could do online guides for tests or medical school or residency. Again, we talked about that a little bit. The Roche Review is a great example of something that's out there where it's these, just multiple questions for your board preparation. Write questions for online quiz banks. You can teach at a university. So if you're community and you're like, I really want to teach, maybe you can try to find an academic position somewhere where you can help teach. Or you could be a tutor, and you could be a tutor for anyone. You could be a tutor for medical students, residents. You could be a tutor for, elementary or middle school. We have a lot of information. We could do a lot of stuff to help out. Okay, I'm going to go into real estate. This is a pretty big category. I'll try to get through it quickly. But it's a great way to make money. There's also some risk in it. So here's a bunch of different things that I found and that I've read about. I have not done a lot of this, although I've had one single family home previously that I sold, so I no longer have real estate. But I have looked into doing real estate in the past. Many of you might have real estate. There's a lot of ways you can do that. So you could buy a single family home or a multifamily apartment building or units. You could then rent them out. There's a lot of ways that you can do that. What you need really is a real estate agent, a property manager, a contractor or handyman, unless you're really handy and it's close to you, and some sort of a lender so that you can make all of this work. So there are ways to do this without actually needing all four of those elements. You could go to a place like Home Union. I put it out here because I thought it was an interesting site where you basically, they do all the work for you. They help vet the properties that go on there, and then you basically buy the property and they do all the rest. They find the real estate agent, they do the property management, the contractor or handyman, and find the lending for you. And it makes it, they take some of your money, but it makes it very convenient for you. You can get good investment returns from this, a lot of times 10 to 12% depending. And then of course it's time to set up and money up front. There is some risk to it, but a lot of people do this very successfully. Crowdfunding is another way to do it. You invest money in a company and basically they do all the rest. So you can go as little as $10,000. You technically need to be an accredited investor. What that means is that you make more than $200,000 per year if you're single, or $300,000 per year as a family, or you have a net worth of over $1 million. Usually fairly easy to do one of these things to become an accredited investor. You can take a course on this. The Passive Real Estate Academy is one such course. That's through the passivemd.com, I think, or passiveincomemd.com. Anyway, there's some different courses that you can take on that, and that can help. And you can see there are a lot of companies that do crowdfunding. Syndications and real estate funds are options. A lot of syndications go through what they do is they go through a sponsor or an operator. And so if you know someone who does this, then that helps. If you don't, then you can look for opportunities. But they basically pool a bunch of capital and invest in one real estate opportunity, and you're the investor or one of them. And then you get rates based on that. A lot of people get 10 to 12% rates back on that as well. And then there are real estate funds where you have private equity and rights and different things that you can invest in, but you're really investing in a vision rather than a specific real estate opportunity. And then other real estate opportunities are things like you can Airbnb your own house or other properties, and a lot of people do that. There are tax lines where someone can't pay the taxes on their property, and so they put out basically a tax line, or I don't even know how to say it, maybe it's a lien, anyway, on the property, and then you can purchase that tax lien line, and then then you can make money off of that. You can also become a real estate agent. So that's an option as well, which is an interesting way to think about this. And then there are a bunch of resources. There's the Real Estate Guys podcast is fantastic. I've listened to it a little bit, and it's really interesting. The Passive Real Estate Academy I told you about. And then Semi-Retired MD are a couple that were physicians that decided to start investing in properties, and they put out an entire course as well as a website out there that talks a lot about real estate investment. Okay, entrepreneurship's the last big category I'm going to go over, and we're getting closer towards the end. So I'm going to talk about real quick. You could start a business. So this could be an urgent care or a locums. That could be your business. You could create or sell a product. I put this out there. This is Dr. Edna's Bare Ease. So all she did was take 4% lidocaine, put it into some sort of cream that you use, and when women are getting bikini waxes, they use this to help out with pain. And she's made a killing on this. She was actually on Shark Tank as well. There are a lot of people who go out there and they create a product and then they brand it and market it in a way that it works really well. So it's certainly an option. You can franchise things as well. Franchise Gator has tons of different franchise opportunities on it that you could look at as well. There's significant upside potential to doing something this, and it's really satisfying to create a product. I've done this before as well with a friend, and that's still in process, but it's a fun thing to do. There is a lot of work that you have to do to get there. It's a big investment sometimes, and it can be risky for sure, but something that can be fun to do. And then you can start an online business. So you can do a blog, like I said, and monetize it if it's doing well. You can do affiliate marketing, which is basically getting commissions on helping people sell their products. So you can do that on your own website. There's different ways to do affiliate marketing, but if you're interested in something like that, there's different crash courses on it that you can look at. You can sell products or different things on eBay or Amazon or Etsy. A lot of people have done this. I've started to do some Amazon stuff with some of these products I'm creating, and it's fun. It's interesting. It takes time to build up that brand, but you can actually make pretty good money doing it and feel satisfied. You could you could create your own online store. Same thing as like on Amazon. You can do it on Shopify, or you could create an app. If you have a great app idea, there's BuildFire or iBuild app that helps you to create these apps that you might be interested in doing. So there's lots of different ideas for online businesses. Another thing you could do is you could do a patent or invention on an idea or a medical device. A lot of people have done this. There's an emergency physician that I know who had the patent on the when we warm IV fluids, the machine that warms the IV fluids. He had the patent on it. He sold it to a company years ago, and he made a little bit of money on it. So there's lots of ways that you could put in for a patent of some sort of medical device or some other idea. And then physician coaching is another thing that's become very big. You can do this for patients, for other physicians, for just anything. You could even do coaching for side gigs, right? So if you look at those categories, there's lots of different things that you can do for physician coaching. I'll go through this one quickly because many of you already know about this, but you could just invest your money, and that can be passive income, or it could be something that you really enjoy doing. So you could do the stock market like most of us do, and just be a boglehead and put it in and let the returns come in. You could be a swing trader. That's usually someone who trades and tries to change up their investments to make some money over usually about a 30-day period. Or a day trader, which everyone understands is that you're making money every day. Takes a lot of work. I don't love the stock market when it comes to this kind of stuff. If you're really good at it, that's great, but there's a lot of risk that goes into it. And so I've tried a few of these things and not been too successful. And so, but it's certainly an option. You can also invest in companies or medical innovation. So venture capital, you can lend like peer-to-peer or hard money type lending. Sometimes that can be great. You can lend money to people who like to flip houses. And a lot of times those people who flip houses have a hard time getting banks to do mortgages. So they get money lent to them, and then you make a good profit off of that money that you lent to them initially. So that's an option. And then angel investing is another thing to think about. AngelList is a place where you can find different opportunities. I think angel investing is, in my opinion, pretty risky. Certainly, if you do it the right way or with other people that know what they're doing, you can come out on top. But it's one of those things you can do. Venture capital, another thing is that a lot of physicians have gone into venture capital and started raising money just because we know so much about the medical industry that we can look at companies that are looking to get investors. Media and public speaking is quick. We all know about this. You can be a social media influencer. You can do podcasts. I put on here Kevin MD because he's very popular as a social media influencer and website. You've got One of our own, Dr. Charmaine Gregory, has done a bunch of podcasts, and she does this Fearless Freedom. You have YouTubers like Z-Dog there, and people who do vlogs, which are video blogs. And so there's lots of opportunities there. Radio or TV, Sanjay Gupta is a good example on CNN, but there's plenty more. You could be a pharmaceutical lecturer. You could be a paid conference lecturer. A lot of people go around lecturing all year long and make pretty good money from it. So these are options. And my last category that I'm going to do is transportation. And I say this because this is really interesting, is that you could be an Uber driver or Lyft, whichever you prefer. It doesn't make a ton of money, but if you have extra time and you want to do it, you get to meet some interesting people, and some people like doing that. You could be one of those people that advertises on your car. You get paid for it. I don't know how many people like doing that. There are people that advertise on their house, which is kind of a crazy thing. I don't think I'd do that, but these are options. You could rent out your car. If you don't use your car that often, you could use Turo or one of those different companies to do that. And then my last thing that I would put on there that I just found fascinating is that if you're a Tesla person, in the future, if autonomous vehicles actually become the thing for real, and we see autonomous taxis and different things like that, Tesla has even talked about creating an option where you literally, you get home for the day, you know you're not going to use your car, you push a button, and your car becomes a taxi and goes around and just picks up people, and you make money for it. So it's not there obviously yet, but it's something to think about in the future. So there's lots of side gigs, and I didn't even get into all of them, but these are just things that you can think about as you move forward. So real quick, this is getting towards the end here, and I know we're maybe slightly over, although we started a little bit late. But side gigs really are in addition to clinical work. There are non-clinical careers for those who are not interested in doing clinical work anymore. I didn't really want to get into a lot of that. And there is a great book that came out called 50 Non-Clinical Careers for Physicians by Sylvie Stacy. She's a physician who runs a website called Looking for Zebras. And if you're really interested in getting out of emergency medicine, you certainly can look into all these different careers that are possible. But I think that emergency medicine is a great field, and there's lots of things we can do on the side. And so, this lecture was really geared at continuing your practice of clinical medicine and then doing something on the side. And, how do you leverage your clinical work to grow your side hustle or your side gig? But the first thing is, I think you have to enjoy your clinical work first. What you do matters. You have to have a positive mindset. I think that for me, I've gone through different times of burnout where I walk into a shift and I just don't want to be there. And I've learned, I guess, over time that what we do really is pretty amazing. And I need to, when I go in on my shift, even if I have all these side gigs going on all at once, I try to get myself in a mind frame that I am there to work and to do my clinical work. And when I do that, I think I enjoy my job a lot more. So that's one thing I would say. The other is that the work up front in any of these side gigs definitely pays off in the end. So if you invest time and you invest in yourself, and it takes a lot of time potentially to do some of these side gigs. Don't just get into something thinking it's an easy way to make money or it's an easy thing to do. I have found that even when something seems like it's going to be easy, something comes up and it makes it harder. There's always a snag when I go to make something new. So always remember that work up front does pay off in the end if you stick to it and you're persistent. Your clinical work makes money. I say use it wisely. You hopefully have some extra money you've been saving up, and that money can be used towards some of these side gigs if that's something you want to do. And then, don't forget the other things that matter in life. Side gigs are great, but if you forget about your family or your friends or the time that you need for yourself, then that can be a problem, and none of these side gigs are going to work out for you. And never quit too early. A lot of people quit too early. I think this is the same for both quitting too early on a side gig that you start. Don't quit too early, because being persistent can help, even when it seems like it's not going well. And also don't quit your job too early. Even if a side gig is starting to go really well, don't just quit your emergency medicine and say, oh, I'm just going to do my side gig, and then the side gig doesn't end up working out. You want to make sure that your side gig is solid and it has a foundation before you quit anything, in my opinion. My framework to get started is don't think like a doctor. We are not taught to think about business and the things that go on in side gigs and all these different opportunities for us. We're taught to think clinically. And so you have to get out of that clinical mindset. We do not learn this in residency. We should learn more about the business aspects in residency, and we're starting to, but we don't still as much. So you want to get kind of outside of the box and think about other things. Actively look for opportunities. You have to look for opportunities to find opportunities, and then you have to seek them out in order to get those opportunities. So I have found that nothing generally comes to me. Every now and then you get a friend that comes to you and says, oh, I got this great real estate opportunity, you want to do it, and it works out. But most of the time you have to seek out the opportunities for yourself. And then again, make sure whatever you do makes you happy, because if it's not making you happy, then it's totally not worth doing. And the last thing is just do it. So if you don't get yourself to just do it and make it happen, it's not going to happen. So if you've been thinking about writing a book for years and you just haven't done it, just grab, I use Scrivener. It's a great little tool that I've used to write. You don't even need it. You can do it on Word and just sit down and write. And that's the best way to do anything, because half the time we think about things, but we just don't act. And if we act, I think you're more likely to get things done and actually see if you really like doing it or not. So that's all for me. I would say thank you. I got a lot of information from Passive Income MD, White Coat Investor, Look for Zebras, and then Physician on Fire. There's plenty of other websites out there that have tons of information on side gigs and passive income and using your skills outside of emergency medicine to do some things you might like. So if you have any questions, I'm happy to answer them.
That's awesome, Greg. That was just a huge amount of opportunity. And I was hurrying up and jotting down notes half the time, trying to keep up with all the awesome ideas you had. So I think that, there's so many opportunities to speak to each different person. And it's interesting to think from the perspective that some side gigs are also not ones that you're making money on necessarily. They're just things like this that you do because you truly, really enjoy being there and doing that. So it was absolutely awesome. Are there any other questions as we wrap up? I know it's been a long Zoom day, and I greatly appreciate everyone coming. Any last questions before we wrap up? Absolutely echo everyone's comments. Thank you for being here to everyone today. All right, I think we have one more shout out to wrap up the day, then Abby's going to close up the conference. If we can pull up Dr. Foland's comments. Dr. Walker Foland is well known from ERCast as well as HIPAA-EM, and has just a few words to wrap up the day, followed by Abby, and then we will see you next time.
Hello, everyone. This is Walker Foland, ER doctor at Covenant Healthcare in Saginaw. Emergency medicine is a temporal specialty. It is a specialty of time. We thrive on putting out fires in every organ system, in every disease process in medicine. We don't own a location of the body like other specialties. We own the emergency. This pandemic has highlighted our strengths. We stand up when others fall. We go toward the danger when others run. We find ourselves at our best saving others, and when no one else is there to do so. And we face these dangers not out of fearlessness. We face these dangers because we can, because we have to, because it is our duty, not out of fearlessness, but out of bravery. We feel the fear of COVID. We have seen it kill our friends, our family, and our coworkers, and yet we continue to stand up to it. Trust me, we all feel the fear of COVID, but we confront our fear, and we do what we were put on this earth to do. We are emergency medicine. We own this pandemic, and in the end, we will win, because we will never give up, and we will never falter, and we will persevere. I've never been more proud of our specialty. It's an honor to go to work every single day. And I'm no hero, but I work with them every day.
All right, we just want to say thank you from me and Therese and Jeff. Thank you all for coming today. Thank you for staying on Thank you to all of our speakers, Dr. Hope, Walters, Hansen, Coffee, and Dr. Gaffney Pappas. Everything was wonderful today. All great, wonderful speakers. We're going to have a couple other CME events again in August and September. We hope to see you there. Again, thank you to ProAssurance for allowing us to offer the CME for free. This is great. Where else can you get free CME, especially in the time of COVID or any time except for having to come to the hospital? I also want to give a big thank you to Maddie and Christy and Belinda, because this could not happen without all of you guys' hard work. Yay! And again, thank you guys for coming and listening today. Watch your emails for all of the information how to obtain your CME. All right. Thank you.
Thank you for all your hard work as well. You and Therese and Jeff.
All right. Stay safe, everyone.